Okay, any of the presenters here? Like the groups?
Yeah, Miss Ramsar, Mrs. Ramsran, Dr. Ramsran, we're here.
Okay, would you like to start it?
Yes,
Yeah,
we
we'll
can.
start.
Yeah.
Let me just share our screen and our slides.
Which topics
Yeah.
are you doing?
We are doing the integrated preventive care clinic.
Yes.
Okay, hopefully everybody can see my screen.
Yes.
Yeah.
All right, so let me know, Dr. Armstrong, if we could start.
Yes, we could start, and I am timing here 35 minutes, right?
Okay, great, thank you. So good afternoon, everyone. Our group today includes myself, Dr. Kavita Panchu, Dr. Michelle Pamasa, and Dr. Robin Ripnarine. Our topic today is designing an integrated preventive care clinic from consultation to population. So within our objectives, we want to introduce a case. We will talk a little bit about a problem level list, as well as an overview of the global evidence, the Caribbean context that we're going to put these problems in, a practical strategy, evaluation plan, and a key message, followed by a Q&A. So here's the case. It's a health center that wants to improve preventive care but faces long wait times, paper-based records, limited staff, inconsistent follow-up, weak referral tracking, and no formal screening register. Patients frequently miss appointments, abnormal results are sometimes not followed up, and prevention is often addressed only when the time permits. So for the problem analysis, instead of delving into a specific root cause analysis or looking into the 5 whys of the problem, we chose to list the ones we thought of into 2 broad categories. So that's a clinical and health system and the socioeconomic and cultural factors. Now, this is not an exhaustive list, but under the clinical category, we know that each physician has a different level of experience or inexperience, leading to varied levels of care administered. There may be lack of continuity of care as well if different doctors are rotating within the health center. Audits aren't done frequently, so quality assurance is lacking. Availability of meds might be inconsistent, so if meds are not on the formulary, patients may have to buy them, or they might just choose to skip them entirely. Staff shortages are always very prominent, and this impacts the time for consultation, which is reduced to about 7 to 10 minutes per person. Medical documentation may be inaccurate or inadequate and sometimes difficult to decipher. Notes are frequently misplaced or lost because they're paper-based. And not every facility may have services like radiology and lab facilities, sometimes hindering the process of assessing the patient. Now, in the other category, we have the socioeconomic and cultural factors. So we thought about transports for patients, especially if they're wheelchair or bedbound. They may have difficulties getting to the health center. Many patients in practice don't even perceive that they have a health problem to begin with. They may wait for a relative, a neighbor, or colleague to feel ill or fall ill, and then they become concerned about their health. Alternative therapies tend to be marketed as better alternatives to medications that have gone through extensive clinical trials, and that could lead to patients abandoning their treatment plans. Some people might anticipate wait times as well, and they don't want to spend half a day in the health center waiting for a physician that they may see for a few minutes, so they may just not go at all. There's also a lack of health education and awareness about what patients should be concerned about and why they should seek healthcare. Meds are costly, as I mentioned before, if they're not provided by the system. And there could be a lack of trust in healthcare providers at times, especially if they look at a particular physician and say, oh, you're too young, you seem inexperienced. Cultural health behaviors are also perpetuated through generations within a family. So, for instance, if a family prefers acupuncture or cupping to other therapies, they may not want traditional healthcare. And with the influx of immigrants, language barriers are very real. We don't have a clear medical legal way to figure out their symptoms and accurate communication. So that also affects our patient care for these immigrants. And lastly, we decided to include poverty and financial instability because when you're choosing between putting food on the table and investing in your healthcare, that could be a really difficult decision to make, and the healthcare aspect gets sacrificed. So in terms of high quality evidence and in the interest of time, our group chose the WHOPAN document for our presentation. So this is a package of essential non-communicable disease interventions. Now, an earlier iteration was created in 2010 and then updated in the years leading up to 2020. Now, this is an extensive document that tackles major NCDs in primary care. So your cardiovascular disease, diabetes, palliative care, chronic respiratory diseases, and early cancer diagnoses. It establishes a template for detection, diagnosis, treatment, and care in countries with poor resource settings. So it provides protocols and tools to strengthen the national capacity to integrate and scale up the care of these entities in primary healthcare. And at the end of the document, it actually includes health center assessment forms just to gauge the readiness of that particular institution. So this document and this evidence is something that could be adapted to use in Trinidad and Tobago. Now, with this high level of evidence, we can improve the risk stratification workflow. And that means we could sort patients into high, medium, low risk. The patients who are complicated and have many entities, or they could be young and healthy. So take, for example, a patient who presents with a cough, difficulty breathing, chest tightness, and wheezing. You might think, is this asthma or is this COPD? You would take a history, possibly give salbutamol, and then assess their peak expiratory flow. And based on that, it might lead you down a specific pathway. So let's say it's COPD, you continue with your assessment and you determine if the patient is in severe distress, moderate distress, or no distress at all. And then you follow the pathway or the flowchart accordingly. So this streamlines patients for many common conditions that they may present with in the primary care setting and even in the urgent and the extended care facilities. Now, we picked out some other guidelines as well. So there's also the CAFA guideline on management of diabetes in the primary care in the Caribbean. And you could see that they grouped patients into two categories. So they put those less than 40 years old and they put others above 40. And they used a validated tool called the Find Risk Diabetes Calculator. So this is a Finnish risk calculator. And by Finnish, I mean from Finland. And what you do is you could go online, input things like your age, BMI, and other factors, and it generates a risk score for you. Putting patients in these separate buckets, so the high risk or medium risk, allows you to prioritize what their care may be and if they need to have further investigations. Another guideline that we will be familiar with would be your Hearts in America's hypertension protocol from PAHO. And this particular algorithm helps clinicians titrate antihypertensive meds safely. So in a way that we're able to screen many patients, we're able to treat them effectively by following these protocols. So on further analysis, in order to address the Caribbean context, when we talk about health promotion in Trinidad and Tobago, there are several challenges. First of all, health promotion tends to be opportunistic and only happens on a small scale on an individual basis. The approach limits the impact that we would have on a broader health community and a broader public health aspect. And additionally, there's a lack of preventive health actions, which is important for people when they want health seeking, when we want to promote health seeking behaviors. There's also varied and inconsistent resources across the primary care institutions, and this disparity affects the quality of care that people receive and that we could give. There's also little investment from the Ministry of Health in health promotion and primary care, which further exacerbates these issues. So we must also consider the demographic and the social challenges, such as an aging population and the double burden of the non-communicable and infectious diseases, which are particularly prevalent in the tropical regions. And we noticed this when we were learning last week about the Omran stages as well. The growing immigrant population too, and high rates of crime, gun violence, these pose additional public health challenges. And lastly, risky sexual behaviors leading to STDs, road traffic accidents, and lack of infrastructure. To support these needs, they add more complexity to the existing healthcare challenges. Understanding all of these factors, though, is important as we move forward to discuss the potential solutions. So let's just keep that in mind when we look at how we're going to address these problems effectively. And for this, I'm going to hand over to Michelle to continue our presentation.
Thank you. Next slide. So what are the solutions to all problems mentioned in our health center case? This health center in our case, as well as many of our local health centers, are faced with the problems of having long wait times and limited staff. What can be some solutions? Some solutions that we brainstormed were optimizing existing staffing, so optimizing staff schedules so that as many staff members as possible are present during peak hours of patient influx. Also, for non-urgent cases, patients can self-register via automated or kiosk system. For chronic disease clinics, there can be a revised appointment blocking system whereby instead of having all patients influx at a particular time, patients can instead be given staggered appointments. During COVID-19, we saw how efficient telemedicine consultations were, so we decided to include this as well, implementing telehealth consultations for very simple visits, for example, prescription refills. Electronic prescriptions and AI chatbot consultations can also be very beneficial here. We also thought that hiring nurse practitioners or physician assistant can also be very beneficial with very simple visits as well. Next slide. Now, I'm sure that many of us have been tasked with having difficulty deciphering colleagues' handwriting, or having patients' own notes go missing, or having patients getting very upset because we have no own notes. These are all problems associated with paper-based records, and how can we overcome this? We can overcome this by converting paper-based records to electronic medical records, and these should not just be restricted to patient records, but also electronic access to patient radiology reports as well as their lab reports. There can also be automated generation of referral letters as well as medical certificates, for example, sick leave. Patients can also have access to their own records. They can have a copy which they can take to different specialties with very easy access. Next slide. What about patients who are lost to follow-up from clinic or have missed their appointments? What about a weak referral tracking system? Well, these patients can have automated reminders in the forms of SMS. Most of our patients have phones about reminders about their clinic appointments. Hard copy referrals can be converted to an electronic referral system whereby the medical records or admin staff can email the electronic referrals to the referred clinic, who can then contact the patients with an appointment. There should be a red flag system in place for patients who have missed their appointments, so that these patients are then contacted to reschedule their appointment. Also, as mentioned in the case trigger, abnormal lab results, there should also be a red flag system in place whereby these abnormal lab results are flagged so that the lab personnel can then contact the physician, who can then contact the patient to get these sorted out. Next slide. Thanks. What about our issue with not having a formal screening register at all? We can adapt a opt-out procedure system whereby all patients who seek healthcare are opted in the screening register unless they choose otherwise. We need an establishment of a national registry, and these need to be there need to be international guidelines to determine patient screening eligibility. These patients should also be sent automated reminders. These eligible patients are seen in the next slide. So here we have a cervical screening program whereby the patients, the eligible patients, are sent reminders, and in this case, it's via an email, where patients are educated on the importance of this particular respective screening tool, as well as information on how they can make an appointment. This is actually functional in other countries, so it can be very beneficial to our population here. Thank you. Next slide. What about the actual practical strategies? So how can prevention be embedded into every primary care visit? So most of our patients, they have access to a mobile phone. So they can be educated and reach out via SMS or WhatsApp. How can we reach a bigger group of patients at every primary care visit? Via group education, as patients wait in the waiting room, and this can be done more than one time per day by many different medical personnel. For example, nurses can educate the patients on medication compliance, dietitian and physiotherapists can educate the patients on lifestyle changes, etc. Also, most patients aren't even aware of all of the services that may be available in public healthcare. So there can be circulation of services available in primary care via cross-promotion of availability of screening tools. For example, screening, eye screening, diabetic foot checkup, pap smear, smoking cessation clinic, family planning advice, vaccinations, etc. I am sure some of our elderly patients may appreciate pamphlets that they can read on their own time or while in the waiting area. What clinic workflow changes would have the greatest impact? In our consultation rooms, it would benefit us clinicians by having visibility of these risk stratification tools in the form of posters, which are posted up in the clinic rooms. For example, the heart protocols, as Kavita mentioned. Staff can be educated on guidelines, for example, via CMEs. Multiple specialties accessible in one in one health center facility. For example, one health center facility can have mental health clinic, chronic disease clinic, a GPO walk-in clinic, physiotherapy, dietitian, etc. in the form of an enhanced health centers, which we do have in Trinidad. EMR or AI scribe implementation would also increase efficiency. Next slide. How can screening, referral, and follow-up be tracked? We already mentioned some of these via e-referral systems, automated reminders, and we can implement a digital dashboard. How can primary care remain evidence-based without becoming unrealistic? We do practice evidence-based medicine. However, not all of the resources in the guidelines may be available. Not all of the tests may be available. We may not have all of the financing available or even all of the medication available. So what we can do is interpret the international guidelines and apply them based on what we have available. For example, as Kavita mentioned, the WHO PEN protocols, which will be more adapted for the lower resource setting like ours. We can also consider the patient's decision and have a shared decision making to help guide these treatments, and also supply or the non-supply would help determine our alternate pathways. So now I'll hand over to Dr. Ripnarine.
All right. Afternoon, everyone. So essentially, moving forward, the digital initiatives are very important. I think the forward movement of any health center or any primary care system, we have to implement technology and we have to utilize the digital options available to us. So therefore, we kind of like propose that we use a user-friendly EMR system connected throughout the RHA, so that no one RHA or no one health center functions in a silo, but is connected to each other. We also would propose that the EMR system also be linked to the private sector, because we have to accept the reality that patients see both private doctors as well as in the public system. And that would allow for continuity of care and understanding, and will also avoid repetition and also mistakes happening for the patient. So interface would usually be something that is very accessible both to the physician and of course his support staff in order to ensure timely delivery of services, for example, his nursing and administrative staff. Next page. Right. So that's the interface that we propose for the physician, but also we have to utilize the technology. I mean, we enter in the fourth technological revolution in the world, which is the AI revolution. Trinidad probably didn't even enter the third or hasn't entered the third properly, which is digitalization. However, the seamless AI assistant, people always worry about AI and thinking AI will replace doctors, but it's quite contrary. AI is going to make us better. So the AI assistant will guide the physician and tell us about any red flags, any things that we might overlook, that humans might overlook like us. So it makes it easy to see. And also it aids us in making our diagnosis, because we will be able to not only see what we think about, but also confirm what we think about and give us possible diagnosis. Right. So the available technology which is being used in other parts of the world is record keeping, and the AI scribe allows the doctor and the patient to talk one-on-one, face-to-face, and therefore getting more value out of that apparent 7 minutes that people in public health centers have to use, and therefore you get a bigger contact time, and that will lead to greater patient satisfaction. So the AI scribe basically records the conversation between the doctor and the patient and puts it down into the notes. Now the benefit for that obviously is greater clinical time, and you know, the common complaint about the patients, you know, the doctor is writing any notes and not looking at me. So therefore the value is increased and the consistency of the record keeping is increased as well. So the AI goes ahead and auto-populates the template, so the physician doesn't have to go through all of that and spends more time with the patient. And also the interface will allow us to almost seamlessly pull any available labs and radiology in an easy manner for doctors at all levels and all ages. The other advantage is the aspect of preventative screening, and that will give us little reminders and flag based on the age and risk of the patient possible screening tests, therefore avoiding misses basically. The great benefit as well, as you commonly see in the elderly population, drug interactions, and the greatest errors in general practice tend to happen at the prescribing level, at the prescription level, especially in Trinidad, because it's not digitalized as yet. And therefore, the AI will allow us to, one, highlight any possible drug interactions. I mean, this is currently being done in the US as well. and it will also enable us to streamline our prescribing. Next. Right, so that's from the physician advantage point, right? But what about the patient? So right now, people are hungry. They're thirsty for education and healthcare stuff. I mean, people are reading up on their own. They go on ChatGPT. However, the value of their information through advertising and through the analog basically comes to questionable content and who's putting out the content. And that's the role of the influencers, right? And some of the influencers are not really validated and not really doctors. So we propose that we're going to have a certain amount of large clinically validated information. So therefore, we drive the population towards seeking that information from this digital initiative, and they seek it from a standardized, validated by us, validated by locally system. And that empowers the patient with digestible information, simple to understand information, and also improves the quality of their consultation. So instead of going from a 50% every time, the consultations move forward, and hopefully we get towards 90 to 100% where we move forward with the clinical care. The interface, we're hoping as well, would allow them to contact, not necessarily only the doctor, but a team who might be able to put them into the clinical appointments and so on. And we're hoping to expand, if necessary, the telehealth service, which was and is semi-in service right now since COVID, and obviously allowing secure messaging and protection of data. Next page. Right, so that's basically what happens in the health center. But as you know, from a public health perspective, the health center is really responsible for the care of the population in that community. So we want to move, I think it'll be more effective if the health center moves from just looking after the people that walk through the door, and we begin to focus on the community as a whole, the population as a whole. We're responsible for the population in that area, in that geographical area, as a health center, not just those that walk in. So therefore, we have to push more outreach and get out into the community. It used to be done years ago to a minor extent, but the push is to get out there in the community. So as we know, we always know about this slang, know your numbers. So we push that. These are examples of community outreach. And in Trinidad, there is a sort of uptake of 5Ks as well. And then we also really need to push the education. We need to get into the primary schools and schools that fall into the geographical catchment area of the health center and give them education. One to avoid the consequences of the things that were listed out in the Caribbean critique, which is familiar to us, for example, sexually transmitted diseases and dengue and so on, and violence as a Caribbean public health disaster, so to speak. But it also allows us to educate them and therefore take preventative medicine even before to put its real genesis, to its origins of preventative medicine is at a kid level, isn't it? So that's what we hope to do. Next slide. Right, so evaluation plan. Well, obviously, evaluation plan has to fall under what we evaluate, what we currently have. And obviously, when you make changes, you evaluate what changes you have along the line. So obviously, I mean, the big word is audit. We have to audit what we do at each step. And audit also allows for us to see whether we get any cost-benefit analysis. At the end of the day, a health center initiative falls under public health policy or public health, and public health falls under a budgetary sort of benefit, where you benefit a large scale number of people at the least cost. So evaluations allow us to push, and KPIs allow us to push that cost benefit analysis more towards the benefit section. So therefore, we would seek to audit, obviously, the infrastructural aspects, which is the long waiting times, and then we get into the clinical aspects, which is more the patient and doctor, which is really the medication compliance, and obviously follow-up. And these are two issues that clinically seem to be a bane of any doctor in primary care's life, isn't it? The medication compliance and poor follow-up. So in any kind of organization, in any kind of structure, when we seek benefit, we have to look, we also measure that by the KPIs. So a typical KPI may look like how many pap smears, if they're uptaking pap smears secondary to our changes in the health center from the traditional model, also tetanus vaccines. And the most important way you could really roughly gauge whether you're working well is by patient satisfaction scores, because some of the other KPIs might be difficult to measure. So moving forward on that, the bigger picture. What is the bigger picture? The bigger picture is that we're increasing mortality and morbidity in the general population. I mean, that's why we do our job, and that's why we're doing all these public health initiatives and primary care initiatives. It's to reduce the amount of people that die. So therefore, we have to look at the big picture, which is the reduction in morbidity and mortality, and also hospital admissions. And obviously, the biggest challenge is non-communicable diseases. So therefore, we have to look at the genesis of the non-communicable diseases and make sure that we see less people who are fat and less people who are obesity, and less people that are smoking and using substances. So it really ties in there. Right. So moving beyond that, the big part of it, obviously, patient education. Now, obviously, patient education nowadays would take a sort of digital format, which I kind of explained earlier in my presentation. But if we're actually in the physical setting of a health center, of the more traditional and still valid way of educating our rural population and our population in Trinidad is through television ads and using the monitors in the waiting room to promote educational material, which you kind of do right now, but I think the quality might be questionable, not in terms of content, but in terms of enjoyability for the target audience. Sometimes they're quite basic. Right, so then we propose to have, while people are waiting around, we give them value for their time, and therefore they feel that they're in a pure educational health environment rather than a waiting room. And that would be led by lecturers from the nursing staff, doctors staff, from people there. And also, we would want to do the organized group walks, which I mentioned before, and group events into the wider community. The other aspect that is very important is that we have to appreciate that the population is becoming more educated. Well, people are becoming more educated. And also, the revolution in medicine is moving towards personalization of healthcare. Rakesh did a presentation there a couple of modules back where he produced all these different wonderful gadgets. The movement in the gadgets were really to personalize people's healthcare so that they take personal responsibility for their healthcare. For example, the smartwatch. So with that basic drive worldwide towards personalization of healthcare, we need to share the online tools and risk calculators with people so that they could take control of their own health. And also they could ask us more educated questions and also get the answers that they want from a clinical encounter with a doctor. The WhatsApp broadcast, obviously, well-used medium, but let's use the medium for non-gossip stuff, and let's push the medium for health. And alerts, for example, whenever we have dengue virus and community problems. For example, they used it during SARS and during COVID-19 in China. I mean, the digital revolution allowed China to sort of maintain its public health policies in the absence of boots on the ground. Next slide. Right, so the key take-home messages, Rome wasn't built in a day, and in Trinidad, nothing happens overnight, all right? So obviously political will to get the job done is the overriding factor, but incremental improvements is very applicable to our society. People are resistant to change and resistant to big change, and also fear for change affecting them. So incremental improvements and measurable incremental improvements in order to get to the destination. The implementation of technology and digital health solutions is non-debatable. I mean, that's essentially where the world has come to, and we need to catch up. And by catching up, we'll be more efficient. And by catching up, we will deliver things with less administrative burden. And a large degree of the complaint from the public is the administrative burden and the barriers to healthcare of the current community or health center setup. Patient education is essential. I went through that for both from us delivering healthcare messages and from them being empowered to seek personal control of their health. The fourth point that the multidisciplinary approach is what people want. It's basically multidisciplinary care in a single setting. So the traditional thought of the rural healthcare, where there's two doctors sitting down and everything walk through the clinic door they see, is a non-efficient model. So patients want to have all the disciplines within as much as possible within the single infrastructural setting, and allowing them to seek multiple physicians or multiple specialties at the same time, and also accessing diagnostics at that center as well. So that will allow the patient in the community to not have to run away to go to a tertiary hospital or a secondary hospital to get simple evaluations to then run back to the health center. That would empower the practitioner in the health center to even follow up the results and allow for continuity of care without lost results and lost time. And that would also lead to a smoother delivery of services, which would improve patient satisfaction. So that is a key hallmark of making things better for the patient. And obviously the continuous quality assessment to make sure that we're improving. And I think the sort of conclusion and main points that we could put in one sort of slide or pamphlet that would encourage the future of healthcare centers in Trinidad. is really the establishment of screening programs. We've fallen short of that so far in this country. And automated reminders for appointments, obviously using the technology. The handwritten cards tend to get lost. The patient education using the WhatsApps, emails, the establishment of a national registry. And the establishment of a national registry goes beyond the great work of Dr. Elizabeth Kwamina, who had the screening registry for cancer. We have to move beyond her work. And that work was done in the 1960s. What we're looking at a screening registry is to have the data and sort of correlate it with use of software to see the at-risk groups, the ages on the registry, and to target them with specific medical and healthcare needs to their ages and to them. So it's no longer a registry of statistics of who have cancers, what type of cancers. Community outreach, obviously we're responsible for the bigger community, so we had to get out to them. That is the goal, that is the metric by which health centers are measured, not what comes in your door, but what you are responsible for. The optimization of staffing schedules, I mean, that's really on the ground, boots on the ground sort of suggestion that sometimes we might see too many staff in the evening, or just sort of optimize it to when the majority of the patients coming in, or when we have heavy flows, at times and periods when we have heavy flows of patients. The establishment of screening programs, training for healthcare professionals, well, I mean, at sort of consistent high level of the practitioner will allow for the continuity of care. I mean, we sort of implement that already with protocols, but we certainly have to educate the practitioners so that patients get consistently good medical care. Adjustment of appointment blocking system. I mean, that is self-evident. If you talk to the patients who are complaining that they have to go into the health center at 8 o'clock in the morning, and there's a ton of masses of people there, that's a barrier to healthcare at best. I mean, nobody wants, I mean, think of yourself. You don't want to go somewhere, you see a mass of people there at 8 o'clock in the morning, and you have doctors there. I mean, let's get real and move away towards personalizing and thinking about the person that we serve. So we're essentially proposing that initially we'll have block appointment times, 8 to 10, whatever. But the ultimate goal is actually, if we could get that down to personal, individual times, that you come in at 10:30, you come in at 10:45 or whatever, and have them seen within a reasonable time period. The implementation of technology solutions, obviously, but behind time in Trinidad, wherever there's a problem, there's a technological solution. That's a push of the world. That's a push of the world going forward. That whatever problem bring to us is a solution. And obviously, the multi-speciality clinic. That's in the past. That needs to be the present here in Trinidad. The rest of the world has moved forward to that, and we need to expand that. I mean, Michelle works in a sort of center there in the east where it works well. I don't remember the name of it. However, we're hoping to have that rolled out to larger amounts of community health centers, and also that'll be the basic aspect of which we're moving forward with our new model of a health center, and obviously continuous quality assessments. Next page. So I think that is our reference here, and obviously that comes to the end of our presentation. Hope you enjoyed it, and we are open to questions. Hope anybody heard me there, yeah?
Yes, we heard you. And
Oh.
quite an interesting presentation. Thank you very much. Some really
You're very
novel ideas that doesn't seem to be too difficult to implement.
Agreed.
Maybe we should send this to the Ministry of Health and the RHAs, right?
I wish. I don't know if that would change the policy making, but it's a step-by-step process, hopefully.
Can help them, give them the idea and let them tweak it.
They will hire nursing assistants and get rid of the doctors out of all of those things.
Good, so pay them less.
It could not be the same. Yeah. So, yeah, from the last slide that you have there, you could place back the last slide. A lot of research went into this presentation, for which I'm very happy about. So this,
Thank you.
Yeah, this blueprint for implementation, what would your staffing look like for this blueprint? What in one health center, what would it look like?
Stuff.
Kavita,
you want to take?
I think we were thinking more of it that depended on the influx. So, for example, we were using Michelle's extended care in Sangre Grande as a example. You know, there are some days that are heavier than others. Like yesterday, Monday, it was really heavy. Thursday may not be. So we were thinking the staffing ratios would have to deal with probably previous statistics of how many patients are coming in on a daily basis, and then make sure you stack enough physicians, you have enough rooms and resources to take care of that number. We used to do a similar layout in the emergency department in SFGH as well. We knew the 2 to 10 shift was heavier, and so we had more house officers on at that time. So I think that's what we were thinking of. And also with that slide where we spoke about hiring healthcare professionals who had a different status. So, for example, your nurse practitioners and physician's assistants, which we know don't exist in the Caribbean, but in other countries, those healthcare professionals can see the non-urgent cases. They could see your asthma exacerbations, your COPD exacerbations, for example, and give them treatment. And then that takes away the burden from some of the more complicated cases that the physicians may see. So I think that's what we were thinking of when it came to staffing, changing the types of staffing that was present and the numbers based on the influx of patients.
And then you spoke about having a multidisciplinary team, meaning that you would like to have specialists at this clinic as well?
Yes. So Michelle, maybe you want to talk about
Yeah.
that one?
Yeah, so I work at the Sangre Grande Enhanced Health Center, and it is one big clinic with many different clinics running at the same time on any given day. So I work in the GP clinic, and in my clinic, it runs from 7 a.m. to 7 p.m. So we actually have a morning shift, we have an evening shift, and then we have a 10 to 6 shift. So the shifts are kind of staggered to suit certain influx of patients. Heavier days would be Monday and Tuesdays, so we tend to be somewhat fully staffed on Mondays and Tuesdays. And then we have the chronic disease side of the clinic, run by the PCPs. We have the mental health side of my clinic, and the psychiatrists, they work there. We have the dental section, we have the optal section, so patients can visit 2 clinics at the same day, which they tend to do and take advantage of. Yeah.
And with that workflow, you have a lot of you have less misses.
We try to have less misses.
Is it electronically kept on a database?
As in data?
Yeah.
Yes, they do keep track of data. Definitely. Yes. They do keep track of data. They compare data every year. We even still have an isolation area where there is one isolation doctor per isolation. We still have the Ministry of Health sheets where we keep track of all of the patients that we see per isolation. The labs and reports are electronic, but we still have paper-based notes. We have a lab as well. We have X-ray, we have ultrasound.
Okay. So my question to you is, how would you balance evidence-based preventive care with the reality that the clinic cannot screen everyone for everything at every visit?
I think in that scenario, we have to take and prioritize each patient. So I know I may have mentioned that health promotion and preventive care becomes opportunistic. So I suppose we may have to, when we speak to the patient, figure out, okay, there are 10 things we need to deal with you. However, we can probably prioritize and choose 1 or 2 to tackle and to investigate further to be able to bring them in again in the future to help the rest of the conditions that maybe we want to treat them for.
The other aspect we're looking at on a larger level is the registry, more or less, is that we really need to keep data on the people that come in, not no big data, but demographic data and so on. The screening right now in Trinidad compared to the rest of the world in terms of primary care is still very lost. So yes, we can't screen each and every patient for everything, and screening is lost. But for example, we struggle to find any data on a colon cancer screening program in Trinidad at the moment, which is a very basic thing. So we're hoping that the reason why things cannot happen and formulations cannot happen into programs is because data and what we call statistics and demographics are very hard to come by on the population. And locally, everybody keeps referring you back to the EBC. That's not the right people to keep medical data or to help us with those sort of things. The old registry, as I said, run by Dr. Pamana, was sort of retrospective in terms of who died from what and who was suffering from cancer. So we really need to start in Trinidad with data collection, knowing who the population is and knowing the exact demographics of the population in order to at least form some sort of improvement in the screening programs and the direct reach into the population for healthcare initiatives. And that's what we found wanting as well when we did our research, Doctor.
And also too, when we were discussing the slide about the screening and the opting in and opting out, what we felt is that we know that we capture patients who have to come in and be
Oh, yes.
registered so that they'll have demographics there already. And to input that information into a system, like Robin mentioned, so that now automatically gets analyzed one time. So we may not capture everybody, but we may capture all the people who are coming into the health center. And perhaps that will trickle down eventually. It's not going to be an immediate effect, but at least you have an area that will give you information. So this person is coming in to be seen in an NCD or chronic disease clinic, and they have to be able to put in, their mailing address or their age, their name, date of birth, etc. And those sorts of things get input into a system that say, okay, this person is a 40-year-old female, she's sexually active, but she's never had a pap smear. So maybe we should alert her that this is something that can be done for her.
And from our research as well, we don't want to discount the fact that she said an opt-out system. That opt-out system, as Kavita was mentioning, there was really come about from the organ donation. We noticed that a huge uptake in people when you have people have to deliberately opt out of a system. It leads to a greater uptake as well because people can be quite non-interested in opting in, but the opt-out system also leads to a greater uptake, and it's proven so to be so true in other parts of the world from our reading.
Great. How would you ensure from this new primary care service improved plan, how would you ensure that there is health equity? Because you're using a lot of technology, you're using a lot of digital access. How would you ensure that there is health equity, taking into consideration the digital divide?
I think this might tie in more to whether or not our country and our nation can move towards a universal healthcare model, because in that way we unify both the private and the public sectors, and anybody can access in these services no matter where they're going to. So, for example, where I lived before in Ontario, and we had a Ontario health insurance provider card, everything was unified there. So I could have taken that card anywhere in Ontario and gone to see any general practitioner I wanted to. And then those physicians are paid by the government. So services that were covered by the federal funds, I had access to all of it unless it was something that just wasn't federally funded. So I would say to ensure health equity, we have to have other changes in policy, other changes in our structure that can unify the healthcare systems that are in both Trinidad and Tobago.
Yeah, and then I mean, your question might be around a technological one as well, and I think the world has moved forward. I think the greatest equalizer in the world is that everybody has a cell phone. There are more cell phones per person than people in the world, and it's already been implemented throughout the world. People use the cell phone, so it's not really a big. And I mean, you'll be surprised. I mean, an older person might think it quite. I'll be looking down on them because they all use WhatsApp as well. So the technology is very simple. It's very, very simple. What is lacking in Trinidad really all the technological services that we have put forward as a solution can be seen on your interface on your cell phone and can be accessed from that. The problem that we face is that the issue, the stumbling block that we face is not really in terms of giving people equitable solutions, equitable amount of information, and or equitable access to medical services. We have actually improved that by this suggestion, by actually having it accessible and in one spot and bringing you out into the multidisciplinary approach in the health center and not making time to go to Mount Hope, and actually getting into your house with humans as well as with the technology. But this little stumbling block might be that Trinidad is still, we now have a ministry of digitalization. We've been talking about digitalization of the public services for nearly 20 years, and we now have a digital, we now have what is called a Nancy. So we're now utilizing the technology. However, the public is way ahead of the government and of the public services. The average man in Trinidad is way ahead of using digital services beyond the government offered services. So we're trying to play catch up. It's actually the other way around. We are behind them. And certainly it's been shown in other countries as well. For example, in the US, in the UK, and everywhere else. Now you say, right, Trinidad might be a little bit poorer than other countries, but the drive is that way. I mean, we're trying to move towards a cashless society as well. So technological advancements will happen. People will not necessarily be left behind. It might become difficult, but it will be brought forward. And also, we have the safety net of the humans. We have the safety net of the physical health center where things could be explained to you, where help can be used by these new hires to teach you how to utilize the technology to your benefit. So we're hoping not to leave anyone behind, if that's the genesis of your question.
Okay, great. So I'd like to ask the other students if there are any questions, anything that you think need to be clarified. I think it was a pretty comprehensive presentation. Thank you very much.
You're very welcome.
And so we are on time. And would you like a 5 minutes before the other presentation?
Yes, please.
Yes. So we'll have a 5 minutes. It's now 4:48. (5:03).
All right, good afternoon, everybody. I am Noreen Boben, and my colleague is Dr. Rakesh Harilal. This evening, we'll be presenting on screening priorities and resource-constrained primary care. What should come first? Rakesh, you can go ahead. So today we'll be covering our case trigger, covering why does prioritization matter in primary care. We'll be comparing high income versus a Caribbean primary care, going through the principles of screening prioritization, a screening prioritization matrix, what constitutes priority screening, first screening versus universal screening, when we should adopt global guidelines. We'll chat about a screening register, recall and reminder systems, referral pathways for abnormal results, missed appointment follow-ups, community screening days, evaluation indicators for screening programs, and we'll chat about a toolkit for screening programs and then wrap up. Slide. So our case trigger was a busy primary care clinic serves a large adult population with high rates of obesity, hypertension, diabetes risk, poor cancer screening uptake, and inconsistent follow-up. The clinic has limited staff, paper-based records, and no reliable screening register. So the key question for our presentation is, if we cannot screen for everything, what should we prioritize first? So today we will explore how Caribbean primary care clinics can develop a practicable, equitable, and evidence-based screening prioritization framework in resource-constrained settings. Next slide. Okay, so and why does prioritization matter? In high-income countries, screening programs are usually supported by strong healthcare infrastructure. Clinics often have electronic medical records where patients have access to all medical investigations as well to their fingertips, automated recall systems, reminder notifications, and dedicated preventative care staff. They also have reliable specialist referral pathways, and this allows them to implement broad population-wide screening programs more effectively. However, the reality in many Caribbean primary care settings is vastly different. Clinics often face shortages of staff, they have limited consultation time, overcrowding, paper-based records, inconsistent laboratory access, and weak systems for tracking abnormal results. In addition, many patients in the Caribbean may experience financial barriers, and this would include transportation costs, missed workdays, and having to pay out-of-pocket healthcare expenses, which reduce screening uptake and follow-up attendance. This is important in Trinidad and Tobago because of the burden of non-communicable diseases is extremely high. Research from PAHO and the Ministry of Health show that non-communicable diseases account for about 62% of deaths in Trinidad and Tobago. Hypertension prevalence is about approximately 25.8%, while diabetes has been rising significantly over the last two decades. More than half the adult population is overweight or obese. This increases the future burden of cardiovascular disease and diabetes. Because resources are limited, primary care clinics cannot realistically screen for everything. Screening activities must therefore be prioritized toward conditions with a high disease burden, simple and affordable screening methods, available treatment, and reliable follow-up pathways. So this leads to a critical principle in public health. Screening without follow-up is worse than no screening at all. If abnormal results are not tracked, referred, and treated, patients may still progress to preventable complications despite being screened. So screening is not just about detecting disease, it's about ensuring continuity of care, after detection. Next slide. So to understand why screening prioritization is necessary in the Caribbean, it's important to compare our healthcare realities with those of high-income countries. In high-income settings such as the US or Canada, healthcare systems generally have greater financial resources. They have a larger healthcare workforce. They have widespread access to specialists. They have stronger preventative care infrastructure. And many clinics use electronic medical records with automated reminder systems, allowing their patients to be recalled for repeat screening and follow-up appointments efficiently. In the Caribbean, many primary care clinics operate with limited staffing, as the previous group discussed, overcrowded clinics, funding constraints, and inconsistent access to investigations or specialist services. In Trinidad and Tobago, we all know paper-based records are still common in a lot of clinics, making long-term tracking of screening and abnormal results more difficult to keep up with. Another major difference is the follow-up capacity. In high-income countries, referral pathways are often standardized and integrated electronically. However, in Caribbean settings, follow-up may become fragmented due to delayed appointments, transportation barriers for patients, poor communication systems. For example, a lot of patients, sometimes they are called over the phone to come in for particular clinics. And most times, over the phone, these patients don't remember the date of the clinic. They don't know the name of the clinic. And a lot of them show up at A&E saying, well, I was called to come to the hospital. I'm not sure where, not sure for why, but I was called and told to come to the hospital. So, and a lot of patients are also being lost to follow-up. Because of these limitations, Caribbean healthcare systems cannot always adopt broad population-wide screening programs used in high-income countries. Instead, we must be more selective and focus on conditions that have a high disease burden, conditions that can be detected easily and affordably, and have available treatment and follow-up options. There's also a difference in disease patterns. In high-income countries, they focus heavy on aging populations, while the Caribbean experiences an earlier onset of cardiometabolic disease, including hypertension, obesity, diabetes, and chronic kidney disease. So the major implication is that Caribbean primary care must prioritize screening strategies that are realistic, high-impact, cost-effective, and sustainable within our local healthcare systems rather than simply copying a model from a high-income country without having proper structures in place. Next slide. So I'm going to go through some principles of screening prioritization. The first principle is disease burden. Screening should focus on conditions that cause major morbidity and mortality within a population. Research from PAHO confirms that non-communicable diseases are among the leading causes of death locally, particularly hypertension, diabetes, obesity, cardiovascular disease, and CKD. This means these conditions should receive high screening priority. The second principle is detectability. Screening tests should be simple, it should be reliable, affordable, and practical within our primary care settings. Things such as blood pressure measurement, BMI, blood glucose testing are just some examples of high-yield screening tools because these are inexpensive, easy to perform, and can help in identifying disease early. The third principle is treatability. Screening only has value if abnormal findings can lead to intervention. The Trinidad and Tobago National Strategic Plan for NCDs emphasizes that prevention-focused integrated care and early management of chronic disease risk factors. Detecting hypertension or diabetes allows lifestyle modification, medication, and monitoring that prevents strokes, kidney failure, and cardiovascular disease. The fourth principle is feasibility. Even evidence-based screening programs may fail if healthcare systems lack sufficient staffing, funding, equipment, or even laboratory access. There was a study that was done by Dr. Bahal and Dr. Legal in 2017 in a Trinidad walk-in clinic, and it showed that the workflow was affected by, clinic time, resource allocation. These things, simple things such as clinic time and resource allocation, affected screening implementation in many primary care settings. The fifth principle is a follow-up capacity. Screening is ineffective if abnormal results cannot be tracked and managed appropriately. There were also some papers that evaluated primary care systems in Trinidad and identified challenges with coordination, continuity of care, and referral pathways. So clinics must consider whether they could realistically monitor abnormal results, contact patients, and ensure referrals are completed before we even think about expanding screening programs. If we can't get the basics down, how can we think about expanding screening? Finally, equity impact must be considered. Screening programs should reduce disparities rather than widen them. WHO and CARICOM emphasize that strengthening access to preventative services, particularly for underserved populations who may experience financial, geographic, or healthcare access barriers. Overall, the goal for screening prioritization is to focus on interventions that are not only evidence-based, but also realistic, sustainable, equitable, and capable of actually improving outcomes within Caribbean healthcare systems. Next slide. So this is a screening prioritization matrix. This demonstrates how primary care clinics in a resource-constrained Caribbean setting can decide which screening activities should receive the greatest emphasis. The highest priority screenings are hypertension and diabetes. These conditions carry a very high disease burden in Trinidad and Tobago and throughout the Caribbean. So screening methods such as blood pressure management, blood glucose testing are simple, these are inexpensive, and it's easily incorporated into routine clinic visits. Importantly, early treatment is available and can significantly reduce complications such as stroke, kidney failure, and cardiovascular disease. Chronic kidney disease screening is also considered high priority because CKD is closely linked to hypertension and diabetes. A simple test such as a serum creatinine or urine albumin testing can identify disease early on before progression. Lipid screening also remains important because this lipidemia contributes to cardiovascular disease. Even though lipid testing will obviously require laboratory access and additional costs, this makes the feasibility slightly lower than hypertension or diabetes screening. For cervical cancer, this is another relatively high priority intervention because cervical cancer is largely preventable with early detection and treatment of precancerous lesions. But implementation depends on the availability of pap smear services, HPV testing, trained personnel, and follow-up systems. I know when certain health centers send off pap smear results, you may tell a patient, okay, come back in 6 to 8 weeks. When the patient comes back, there's still no reports available. Then you have to tell your patient, come back in another 6 to 8 weeks. And sometimes, due to constraints, a long time goes before you even get results for a simple thing as a pap smear. Breast cancer screening also received a moderate priority level from us because mammography programs require greater infrastructure, imaging access, and specialist services eventually, and reliable follow-up pathways. In resource-limited settings, widespread mammography screening may be difficult to sustain. For colorectal cancer, this is increasingly important due to the rising disease burden, but the feasibility remained lower for us because colonoscopy services and organized screening systems are very resource intensive. Prostate cancer, the screening for this remains a bit controversial internationally as well because PSA testing may lead to overdiagnosis and unnecessary investigations. There's a lot of guidelines that state shared decision making should be involved rather than universal screening. Overall, this matrix that we came up with emphasizes that screening decisions should not rely solely on disease importance, but clinicians must consider the simplicity of testing, the availability of treatment, affordability, staff capacity, and the ability to follow up with abnormal results. This allows our Caribbean primary care systems to focus limited resources on interventions that are most likely to improve the population health outcomes. I'll now hand you all over to Dr. Harilal.
Okay, so when we digging in now to the highest priority screenings, we want to focus on the high burden conditions that, again, as we said before, that are easy to screen for, affordable, and highly treatable. We can see that we talk about hypertension, the diabetes, and obesity. Top priority because these three here lead to the highest disease burden right now on society, the NCDs, leading causes of stroke, heart failure, kidney failure, sleep apnea, osteoarthritis, dyslipidemia. So across the board here, these are easy tests to perform at every visit that essentially are universal screening for all adults, whether it be it opportunistic screening or whenever we get chance, right? In addition to what we usually do in Trinidad, we see some new tests coming out where we, instead of BMI, we want to check waist circumference, which kind of includes a greater population of people who may be at risk for hypertension and diabetes. Because if we could remember from our previous module, 29% of people have increased blood pressure in Trinidad, 15.9% and increasing have a raised blood glucose. All right. We looked at the tier 2 high-value screenings, which essentially was your lipid screening, your CKD screening, and your cervical screening. So while these are still high-yield conditions to check for, they require a little more investigation burden to try to see if it have any irregularities. So most of these here, you need to either go to a lab or you need to have a on-site examination performed. And that's going to increase your time needed to either perform the examination or wait for lab results. Your tier 3 screening now, again, these require specialized equipment sometimes, as well as if any abnormal results found, specialist intervention immediately. So that's your breast cancer screening, your colorectal cancer screening, prostate cancer. Now, for breast cancer, we have the mammography and the clinical breast examination. There's a increased clinic visit time. Now, not all areas gonna have mammography units, as well as the time it might take to get a mammogram done. I think right now, I think the wait time is 2 weeks from the health center for an appointment to be made and then to actually get it done. Right? The colorectal cancer, while it's increasing, again, we don't have the capacity to do colonoscopies on everybody at a short space of time. The cost to do a colonoscopy privately gonna push more people into the public system that cannot handle that volume. Prostate cancer, as we spoke about before, why we can't do the PSA, we're really looking at what value we want to do that gonna include more men into that, and then you're looking at over testing, then over diagnosing, and then over investigations. So really want to ask yourself, how are we going to screen? Are we going to try to do a risk-based screening assessment versus just screen everybody? So with risk-based screening, we focus in the resources on the people highest at risk, and that will be the most efficient use of the limited resources. We're looking at a higher yield of positive results per the test, and potentially it is more cost effective. And again, it would align with targeted prevention and treatment. But we're going to miss a lot of people who are at risk but not identified. And you're going to need people who could accurately perform that risk assessment. And that's either going to be limited by data or the tools at hand. And that is what's going to widen the inequity. If the risk-based tools, you can't really access them. Now, the complexity of the system required to follow up with these people going to increase the more we screen people, and it has an overall lower coverage and population impact. Your universal screening, basically everyone has equal opportunity to be screened. Now, if you screen everyone, you have a better chance at finding undiagnosed diseases earlier. And these are usually simpler to implement and communicate. And technically, it will promote equity and reduce disparities and lead to earlier treatment and better outcomes at a population level. But you're going to be sucking up a whole set of resources, and it's going to be very expensive. You're going to include a lot of low-risk individuals, and that is going to decrease efficacy, and you're going to have a higher chance of false positives and overdiagnosis, as well as overtreatment for patients who may not have the disease. And if you're screening everybody and have a larger amount of people who are getting positives, you're going to need a strong system to manage that volume. And definitely is not going to be sustainable in our resource constrained setting. So what are we going to do? We need to do a hybrid strategy. So essentially, we're going to screen smart and use resources wisely. So for universal ones, we want to use a cheap and reliable source of testing. So BP measurement every visit, BMI or waist circumference every visit. We check in smoking status, as well as target the high-risk individuals who need the individual testing. So people with risk factors like being overweight, have a family history of diabetes, hypertension, who actually have hypertension already. We're screening them for diabetes. People who have diabetes, hypertension, smoking, past history of CVD, screen the lipids, screen for CKD, and age and risk-appropriate screening in females for cancer, as well as men. In the Caribbean and Trinidad and Tobago, the high rates of hypertension and diabetes, obesity and CKD is staggering. But to test everyone against our limited staff, time, and resources is not feasible. We need to focus on high impact screening and ensure that we can follow up with these patients and ensure proper referrals and tracking. So when do we adapt global guidelines? So as the previous group had discussed, as well as we try to discuss as well, most global guidelines will come from high income countries, and they will assume that the system is strong and there's an established infrastructure. And through that, we can ensure high reliable follow-up, as well as specialist access immediately or almost immediately. But that is not true for the Caribbean, not more or less for Trinidad and Tobago. So when do we want to adapt the global guidelines? When the test isn't available, when we cannot follow up, or the follow-up is not feasible, and the cost of the accepted guideline is too high. So for example, if we want to do primary testing for HPV, that may not be available in all health centers or outreach programs. So we'll try to do pap smear where HPV testing is not available, or the visualization under the acetic acid. Universal mammography is definitely not feasible in Trinidad and Tobago right now. So we would need to lower the pool, which is focusing on high-risk women. And frequent lab-based monitoring, again, will overburden the entire system. So again, we have to simplify the risk-based assessment for follow-up. What we're trying to do is essentially an ethical consideration. We're balancing the ideal care needed for this patient versus the greatest population benefit. Now, in our research, we saw that in the South, in I think Southwest, there's a summary sheet being used right now. Now, this is on the patient level. Every patient now will be assessed. They'll have their clerical and demographic information logged. And now you could actually work through and log their information in their file. And we can see here every visit now, the patient will have their BP, pulse, weight, RBS, if they're still smoking, what they counseled on. And this again, every visit and the date. So at least there's some tracking going on. Then every 3 to 6 months, again, we could log when it is, what value, and then we move on from there. And then long-term tracking now, again, in the patient file. But what we can see here now is a paper-based login of the patient information. Now, in the first world countries, everything more or less is digitized. So tracking is much, much easier. Where we can't have digital or is not implemented as yet, paper is still useful. It's better to have paper than try to implement a whole set of complex tests and then have a system fail, right? Right now in the South, I know Point Fortin Hospital, accident emergency and clinic using the Selma system, which essentially is an online platform where patient records, lab values, as well as referrals can be attributed to a doctor account and then traced back to either referring to the different clinics or even like places like physiotherapy. So you can be in an outreach center, like a health center, interact with your profile, log the patient information, refer them, and then the doctor on the other end can go through and actually see what the patient need, accept or decline the referral, and then both doctors don't have to be face to face, can interact over the platform and ensure proper follow-up of the patient. Now, in addition to the Selma program, which is the online platform, I believe the obstetrics and gynecology clinic in South using the SIPS program, which further integrates a lot more of the patient records. So we are moving towards a more digitized landscape. But again, that's one RHA. And as the previous group had said, we need a more broad umbrella program to more or less cover all the RHAs. So even if a patient was in one RHA and needs to move to the next, it's not going to be difficult or have loss to follow. So why we looked at the patient, this is on the patient level now, we need to talk about the screening register. So many Caribbean clinics going to rely on, again, paper records, memory-based recall, opportunistic follow-up. I spoke to someone who working in Blanchisseur's Health Center. They just writing in files and based on the patient individual characteristics they're gonna do for screening, and whoever could read the file after gonna see, okay, maybe we should try to follow up here or not. This is gonna lead to lost abnormal results, patients missing vital signs of cancer, poor chronic disease control, right? A basic screening register, whether it be digitized or paper, needs to include the patient name, age, the screening due dates, the results, the follow-up actions, and the referral status. Whether it be paper or digital, no tracking leads to misdiagnoses. This is just a slide describing the differences between the paper-based and the digital screening. Again, with paper, limited access, high risk of errors, very time-consuming, very hard to follow up on. If there's a flood or fire, basically the entire thing gone. You need a lot of space to hold it down. The one good positive is that it's cheap to start, but again, going forward over time, hidden costs like printing, storage, staff time, all of that are gonna add up, and it's very hard to scale if you want to do from health center to health center, trying to upscale the paper base. But with digital, easy access, improve accuracy, is automated, easy to follow up. It may be more secure. We know it had a data breach in South, but again, we've moved on years from that. Everything is much more secure now, saving space and costs, right? With respect to recall and reminder systems, what we want to do, routines, we want to make sure patients know when their routine screening is due. We want them to know when they have abnormal results, with respect to follow-up and repeat testing, and we want to monitor their chronic disease. Some low-cost reminder strategies. While they may have a phone, some people don't know how to interact with a phone, or we just have some old people in the rural areas who just don't want to digitize. We could also do WhatsApp messages for those with phones, but we need to basically make sure that we cover the entire population. Not the middle and high class incomes alone need to be recalled and reminded. Regular phone calls. We saw in COVID that telemedicine made a big impact with respect to following up on patients with and without COVID. We still have appointment cards where they might be a little bit difficult to use. That still gives the patient a chance to have a tangible reminder. Letters and SMS. So basic texting can still work. TT posts, whereas in the past it might have been unreliable, it is reliable today. And for the patients who are very difficult to reach in the rural areas, community outreach. We need to go out and help trace it and remind the high-risk patients that they need to be followed up, right? We need patients to know about their dates before the due date, at least 1 to 2 weeks. And if they miss an appointment, contact them within 3 days. If any abnormal results, we need to tell them. And we need to repeat and retain the cycle so that it will continue. If there's abnormal results, what do? We screen the patient, we see the result, we need to refer and make sure they receive specialist care. Once we can get feedback, it needs to come back to us so it have no discontinuity of care. And once we could continue screening, we could repeat the cycle. To make sure the system work, we need to make sure it have a defined referral sites. We're not just giving the patient a piece of paper and send them out into the wild. We don't just send everybody. We need that criteria to make sure we utilize all of our resources. Communication process. We need to make sure that we can contact the lab can contact us, we could contact the specialist, and they could have that open line of communication. Again, we need appointment tracking. We need to know who log in it, making sure patients know their days, and make sure there's effective feedback. If a patient misses a follow-up, what are we going to do? The high-risk patients, the ones who have the severe hypertension, uncontrolled blood glucose, CKD, the ones who might have abnormal result from the positive cervical cancer screening, patients who can't see, what are we going to do? Again, can't just be all digital right now. While we are moving towards digitization, we need to make sure we can do phone outreach, community outreach, make sure patients can be flagged when they have abnormal results. And again, it's not just one person we're dealing with. You need to be the holistic care. Engage the family, engage the caretakers, and make sure we have dedicated follow-up days for these high-risk patients. With respect to community screening days, we want to make sure that we could have the staffing to go out into the community and increase the reach for the rural areas, for the patients who cannot make it to the health center, who don't have the money to come, right? We need to raise awareness that chronic diseases need to be monitored and maintained to increase longevity, right? So how are we going to evaluate the screening programs? There are multiple indicators we need to look at. So the process indicators, how much of the patients are screened, how much are eligible adults are screened for diabetes, the hypertension, how much BMIs are logged, how many, basically, essentially, how many people are getting the screening done. And once we can do this and make sure they are screened and referred, we need to see, okay, how many new cases of hypertension and diabetes or patients who have controlled their chronic disease are being picked up, If we pick up a cancer, how early we do it? We're trying to not pick up patients who are stage 4, maybe stage 1 or stage 2, right? The earlier we pick it up, the better outcome. We want to see system indicators. Are we completing referrals on time? Are we going to get abnormal results to patients in a timely fashion? Can we complete proper data entry? And can we repeat the screening cycle effectively? And equity indicators. Can we make sure that a large volume of the population being contacted? Can we make sure we have almost equal male, female with respect to cancer screened? Can we make sure across the ages are screened properly, right? We want to collect accurate data, analyze and identify the gaps, implement and improve, and then monitor and reevaluate. And that's essentially better for the entire population. This here now is just a more or less a toolkit or pathway for the screening programs that we identified, right? We said we wanted to prioritize the high burden conditions. So high blood pressure, diabetes, CKD, cervical cancer. Then use feasible tests. So while we have global guidelines, if it's not applicable or high cost, we need to adapt. So once it's affordable, accurate, and acceptable, we need to use these. And then we need to look at the system capacity. So we can't just expand screening based on global guidelines and then the entire system collapses. We need to know that it have the laboratory capacity, the specialists and the referral systems can handle it, and that once we pick up something abnormal, that patients can be treated and that we have these systems and the workforce in place to treat them. Once we could track the screening, the recalls, the referrals, and then have effective communications, we can now continuously evaluate and improve, identify the gaps, and move forward, right? This here is just again the prioritization matrix that we looked at. We want to just make sure that we identify the high yield areas, hit them fast, hit them hard, and then look where else we can allocate our resources. Trinidad and Tobago, and by extension the Caribbean, we do not lack screening guidelines, but at the moment we lack sustainable systems that can consistently identify high-risk patients and ensure follow-up and deliver equitable care. Primary care is resource constrained, yes, but the goal is not maximal screening and one for all. We need to be strategic in screening and then produce meaningful healthcare outcomes. Thank you. There's some references.
I like how you synthesize a lot of information on these slides. It was very, very informative and builds a very good picture of, looking at multiple indicators and considerations in one. So that was excellent. My question to you is, what are the ethical risks of screening patients when the clinic cannot reliably follow up on abnormal results? What happens?
Well, the general rule is that we cannot screen if you cannot follow up. It makes no sense that you screen a patient for disease and then they are left wondering, okay, how do I try to solve this or how do I try to fix this? Through all the reading that we saw that basically we must, before we screen, we make sure the system can adequately allocate resources to following up with the patient, treating the patient, and further management. So the system that and the matrix that we design, we kind of get towards, okay, once we could screen the patient, we know that downriver that there's place for treatment and management of the patient.
From your first slide or the second slide, you said that 61% of our population was obese, and obesity is a precursor for diabetes. However, only 11% of the population is diabetic or estimated to be diabetic. Oh, how would you account for that?
Nilini, you want to take that one?
Sorry?
Can you repeat that?
If you go back to the first or second slide,
Right, 12% diabetic and about 62% of that's attributed to non-communicable diseases.
obesity, diabetes and obesity. So NCDs are 60, well, hypertension, right? Diabetes is, let's say 11, 12%, but overweight and obesity prevalence is 61%. And
Right.
obesity is a precursor for diabetes.
Right. So the overweight and obese patient, most of the times they have a lot of different conditions affecting them. So we have most of the times a lot of them don't just have one chronic disease, they have multiple. So cardiovascular disease, diabetes, some of them have CKD. Being overweight and obese does lead to a lot of different follow-up conditions. So I guess, and that's why, sorry, what was your question? I was just busy doing something. And why does NCDs account for 62% of deaths?
No. Being overweight and being
Right.
obese is a precursor for diabetes. However,
Right.
the prevalence of obesity is 61%, but the prevalence of diabetes is only 12%. Wouldn't you expect it to be more than that?
Well, it depends on when these studies were done, how much screening was done, and how much of that screening was documented data-wise.
And
The
it's
values
steps
could very well be
2024.
different.
What did the steps 2024 say?
Um,
Remember, steps 2024 said that there was a large population which had 3 risk factors for NCDs. Steps 2024. Don't you all find that quite interesting?
yeah, it's interesting. I don't recall everything from the steps 2024, but it is definitely interesting.
Okay. In a clinic with limited staff and with no screening register, which 3 screening activities would you prioritize first and why?
We'd want to do the blood pressure monitoring, the random blood glucose and a BMI or waist circumference. That should account for our 3 highest burden conditions, which would be the hypertension, the diabetes, and obesity.
Yeah, and it will be feasible and cost effective.
Yeah.
At the level of history taken, what risk factors would you try to, and how would you go about it? How would you assess risk at the level of history taken? Because we've spoken a lot about physical examination and we've spoken a lot about laboratory investigations. But they are validated. Sorry, go ahead.
No, finish.
What would you do at history taken to assess risk?
Well, firstly, it'll be I'll look at 3 areas. One, initially we'd want to understand the patient himself. So certain conditions are linked. So obesity, we're looking for if the patient also have diabetes, hypertension, dyslipidemia. We want to look at family history. So if the patient has a family history of any of those, again we know there is a familiar link. So we'd want to class those patients as high risk, as well as we want to approach the patient holistically. So lifestyle. So outside of the clinic, is the patient eating healthy, have a proper diet if they're exercising properly? Because we know that patients who have poor diet, not exercising properly, eventually become obese and then lead to again the hypertension, diabetes, and obesity, which accounts for most of the NCDs.
Yeah. In addition to that, you also have like validated questionnaires that you can use. So you could use like the PHQ-9, the G87, and you know, there's a high incidence of depression and anxiety with diabetics and perhaps with hypertension as well because of the hyperinsulinemia. There is a stop bang questionnaire that you can use for obstructive sleep apnea, which would be in your obese patients. So those are validated tools that you can use, which would help. You have the Audit C. So those are screening tools that could be used at that level as well.
Yeah.
Yeah. And it is low cost or no cost.
Yes.
Time. Okay. Very good presentation. Well appreciated.
Thanks.
Will you take another 5?
Yeah.
10 minutes. We'll be back by 5. It's 5:41, 5:50. Yes?
Yeah.
Okay. Let's go. Ready?
Hi, yeah, ready.
Yeah, let's go.
All right, just let me know if I'm just trying to get it full screen.
Sure.
So, our assistant say, how am I getting it full screen? I'm not going full screen.
Go to
You
slideshow
you all I pressed that just now, didn't work. Go press it again.
and then try from beginning.
Oh, you all seen it there now?
Yep.
All right, cool, thanks. All right, so I'm Vital Jaina, right? And Kasmira and I will be presenting prostate cancer screening and shared decision making in Caribbean men. So we on the menu, we're looking at an anatomy of the prostate gland. We'll be looking at prostate cancer screening. We look at a case and we'll dig a little bit deeper into shared decision making, risk-based counseling, assessing risk factors. We'll look at the teach back method. We'll pay a little bit also into false positives and overdiagnosis and look at the available men's outreach programs. And we'll wrap up by looking at documentation, informed consent, and follow-up. All right, so the prostate gland is a small gland, a walnut-shaped gland in the male reproductive system. It's located deep in the pelvis. It is inferior to the bladder and just anterior to the rectum. It is divided into zones. You have the peripheral zone, transition zone, and central zone. And these are clinically significant because most cancers would occur in the peripheral zone, while the transition zone, which is periprostatic, is the most common site for benign prostatic hyperplasia. It makes sense though, as the gland would enlarge, you would then to get the lower urinary tract symptoms. So the function basically to produce seminal fluid, and when its smooth muscle contracts during ejaculation, you will get semen being forced through the urethra. Its blood supply is derived from the internal iliac artery, and those are the prostatic arteries. Its venous drainage, it comes from the prostatic venous plexus, and those empty into the internal iliac veins. And the lymphatics, they drain into the internal iliac, the obturator, and the sacral lymph nodes. And these are important when you're actually looking at metastatic disease. So the Caribbean has the highest burden of non-communicable diseases in the Americas. Cancers make up quite a significant portion of that. The rates of death from colon, breast, cervical, and prostate cancer are about 2 to 9 times greater than in the US. Of note, prostate cancer would account for about 18 to 47% of all cancer deaths. Now, we have some risk factors to look at here for prostate cancer, and the top 3 points you see there: increase in age, family history, genetics, race, ethnicity. Those are the main ones we have to look at. As age increases, men greater than 50, they tend to have an increased risk of getting prostate cancer. A family history, we have a first-degree relative, so a brother or father, you have increased risk. And genetics, people who have the BRCA gene or Lynch syndrome, they generally at a higher risk. Race and ethnicity, and this is where the Caribbean actually comes in. Afro-Caribbean males tend to have a higher risk of getting more aggressive disease and getting prostate cancer. Stuff like diet, they attribute things like polyunsaturated fats, obesity, and physical inactivity have also been attributed to it as well. Smoking, we know, causes everything. Also chemical exposure, and there's also been some thoughts that recurrent prostatitis can lead to prostate cancer. So patients generally who get prostate disease, prostate cancer, they could range from having no symptoms, so they're asymptomatic, to having metastatic type symptoms. So it really depends on the stage of the disease. So if somebody has metastatic disease and they have spread to the lower back, they may have back pain. If they have spread to the brain, they may have seizures or signs of a stroke. And the more common symptoms you might find would be frequency, nocturia, hematuria. They might even present with acute urinary retention. Now, in a nutshell, we've been talking about screening a lot this evening. And so in terms of cancer, anybody just want to say what would be screening in the realm of cancer? What kind of definition? Simple terms, what would it be?
You want to pick up cancer in an early stage where it actually have an impact on the prognosis or the mortality.
Yeah, thanks, Nick. Exactly. Yeah, that's what you're really screening as the reason you want to screen. So why we want to screen and why we want to have heightened screening, especially for prostate cancer, is that the Caribbean has some of the highest mortality rates in the world. And the Afro-Caribbean male, just as I said before, have a likelihood of developing more aggressive disease. So the key reasons you want to identify it is because you want to identify high-risk disease. You want to make sure you could get early detection and treatment, and you want to really reduce mortality. So we have some prostate cancer screening guidelines here. I chose the American Urology Association guidelines as I figured their population was closest to ours, and there wasn't really any guidelines Caribbean specific. I looked at the Caribbean Urology Association, didn't really find anything. So we look at this flow diagram, pretty simple, a lot of lines. So I'll just break it down. And the first thing you'll see is that we start in here with something called shared decision making, and this is the basis of everything. And we would move on to what it is in greater detail later on. But basically, for now, it's just think about it as a collaborative effort between the doctor and the patient, and in formulating a process of how to move forward when dealing with your disease. So your age to initiate PSA screening. PSA screening. For the average risk patient, it is advisable to start at 45 to 50, whereas somebody who may have an elevated risk of having prostate cancer when he's at 40 to 45. So you go back to those risk factors that we talked about before. So when you do a PSA test, well, you could either have a normal PSA test, and if the PSA test is normal, where they continue to routine screening, which could be guided by risk factors and your PSA value. And then you could also have an elevated PSA. If your PSA is elevated, you may want to do a confirmatory PSA if the patient is asymptomatic and appears to be low risk. And at this point is where you might want to add in a DRE to help in the diagnosis. So now at this point, if you have a confirmatory PSA that is elevated, you did your DRE, you might want to move on to what we call the elevated risk evaluation, which we'll go on to on this slide. Again, now you might be entering the realm of whether a patient should have a prostate biopsy. So again, you go through what we call the shared decision making, and you talk to your patient. You talk about the risk of doing the biopsy and the risk of identifying a low-grade cancer that may have a low risk of mortality, which could just be monitored. You also discuss with them that you could possibly use a MRI, or could use adjunctive biomarkers such as 4K test, ISO-PSA, PSA3. Those basically, when you use those, they give you an indicator of the risk. So then you'll know if to proceed to the prostate biopsy. So I actually learned something. The prostate MRI, when you do it, there's actually PIRAD score, which is similar to a BIRAD score and TIRAD score as you would use in breast and thyroid disease. And what they basically say here is if you have a PIRAD score that's 3 or higher, you'd want to move on to the prostate biopsy. And if your adjunctive biomarkers are positive, you want to move on to your prostate biopsy. As well as if you did shared decision making, you could skip the adjunctive biomarkers and the prostate MRI and move straight to biopsy. Now, when we get into the realm of the biopsy is when we refer in our patients to our urologists to generally have these things done. So now one of two things will happen. You have the prostate biopsy. You might find, well, okay, they found cancer, and at that point, you'll have to be seen by a urologist and maybe an oncologist. But then, if the prostate biopsy is negative, well, they come back to the general practitioner. And that's when basically in this slide, you see after negative biopsy, we just basically go through the process again of risk evaluating and using a PSA to guide further screening and interventions. So those guidelines I showed you guys there, that was from 2023. So the American Urology Association made some updates to that in 2026. Basically, they got more concrete evidence to support doing an MRI prior to biopsies. They reiterated that the average risk and high risk screening ages, and they emphasized that a more personal approach should be taken when dealing with prostate cancer screening, because you want to maximize detection while minimizing the risk of overdiagnosis and overtreatment. They stated that you should use PSA levels to guide the screening interval. So if your PSA is less than 1, patient could be screened every 2 to 4 years. Your PSA more than 1, you screen every 1 to 2 years. And then when you should consider stopping screening when patients attain the age of 70 to 75, or if they have a life expectancy that's less than 10 years. Now, a little note on the DRE. The DRE is not an effective standalone tool. It is only useful for evaluating patients who already have elevated PSA, and it basically causes unnecessary anxiety and has a low predictive value. The main point here is that they wanted to emphasize that the PSA is really the first line screening test, and only if this is abnormal, we move on. So our case trigger here is that we have this 58-year-old guy. He wants to have a PSA test done because his friend was recently diagnosed with prostate cancer. He's anxious and he believes that doing the test is always the safest option. He has had limited understanding of the false positives, overdiagnosis, and possible downstream investigations. And this is where we would try to highlight certain aspects of the screening in our following slides. So as I said before, shared decision making is the big thing, and it is a collaborative process. Your healthcare professional, the patient, and relative, next of kin, the more the merrier, that you could involve in the process to get information across and answer people's questions. That's what you really want to do. It empowers patients to make the right decisions for themselves, and you really want to ensure that the person understands the risks, the benefits, the consequences of what is being done, and you do this through open dialogue and basically sharing information. You want to offer information to the patient and relatives and whoever else might be there throughout the entire process. You could share this information through multiple modes. You could do it in a face-to-face manner. You could do it via telephone, video conference. You could use books, pamphlets, anything to educate the patient to get the information out there. As I said before, you could ask them if they want a relative or friend to be with them, engage actively in discussion, and you really want to make sure to explain what matters to the patient. You want to use reliable, high quality resources. So you want to use things, evidence-based stuff. You don't just want to pull things out of a hat. And during the discussion, you want to make sure that you agree on a given agenda, stick to your agenda, provide information while allowing the patient time to assimilate the information and formulate questions. You want to give the information in chunks. We'll talk about the teach back method a little bit later. We want to discuss again what matters to the patient. Accept that your views and the patient's views might not always align, but you have to respect their views. And at the end of the day, you want to state clearly that whatever decision that you make, the patient can feel free to change their mind, and you could review these decisions and come up with a new plan at a later date if they so desire. You want to make sure you record everything that was done and everything that was stated in the clinical records. Now, we utilize this decision aid in shared decision making, and it basically is evidence-based tool that assists patients in making their decisions. And these tools could be a wide variety of things. It could be pamphlets, books, websites, anything that will give patients information, and they can be used prior to the consultation, and could even be used during the consultation. So when used prior to the consultation, it gives the patient the opportunity to review literature, have questions that may be asked to them with answers that they could formulate and get more questions on. And basically, when used in the session itself, it could guide the clinician as well to make sure they don't miss anything and that all loose ends are tied up. And the benefits really here is that the patient has a better understanding. You will get more participation from the patient. And then after the patient makes whatever decision together with the healthcare professional, there'll be reduced regrets in the whole process. So this is just an example. I'll just read through one of the questions, like a typical question. So am I at a high risk of prostate cancer? And then the answer is, on average, 1 in 6 men will get prostate cancer, but some men at a higher risk. And this is where you go into the risk factors, including Black men, men with close relative who had disease. So if you're not sure, your doctor can help figure out if you're at high risk. And you use it as a tool to guide the patient. Now talking about risks. Now we have to be careful when we describe risk, as people have different perceptions of risk. And as physicians, sometimes we tend to overestimate the risk of a condition while underestimating the risk of complications and adverse events. So it's important to always remind patients that any option you choose may have some risk, You want to use absolute risk rather than relative risk so that you could reduce bias. If you have an opportunity to use visual aids, that would be preferable. You try to use simple language that everybody can understand. And be careful when you present the numbers to patients. So you don't have to do this with all patients, but there's sometimes you have to assess the patient numeracy. So if you think the patient might have issue with he may not be very literate, we find it a little bit slow. These are just two questions you could ask here that would give some indication as if they could handle the information when you were to give them it in numbers. So you could check that out. So when discussing numerical information, you want to use numerical data once it's available because people tend to accept that more. Be careful with the terminology you use. You want to state the risk of events that increase, instead of saying that something doubles, because when you tell somebody something doubles, they immediately get frightened. But if you say, the risk went from 1 in 1,000 to 2 in 1,000, I guess you could still formulate that, it's still not that big a risk. And they want you to avoid using percentages, as sometimes that too could skew people's thought processes. Be consistent with your numerical data. So, if you tell somebody, well, 1 in 1,000 people could have this, don't go and tell them the next one is like 5 in 20 could have this, because that might just mess up the whole process as well. Put risk over a period of time if relevant, so it will put things into context. And you want to try to use both positive and negative framing. So example, the treatment will be successful in 97 out of 100 people, and it will be unsuccessful in about 3 out of 100 people. It would frame things better. All right. So I'll hand you all over to Kasmira here. She will go through risk-based counseling approach.
Okay, good evening, everyone. So now, based on our case trigger, we're going to look at different ways that we can actually speak to our patient to ensure that the shared decision making comes together and he makes the right decision in terms of prostate cancer screening, whether he has to do it or not. So we're going to talk about risk-based counseling approach first. So a risk-based counseling approach in healthcare is a structured method of patient engagement that focuses on understanding, communicating, and managing the potential risk and benefits of a treatment, intervention, or health decision. So it is designed to ensure that patients are fully informed so that they can make informed, autonomous choices that align with their values, preferences, and circumstances. Next slide. So combining this with prostate cancer screening. So we're using our risk-based counseling approach to tailor the discussion and screening recommendations to an individual man's personal risk factors, health status, and preferences, rather than applying the same advice to everyone. So instead of routinely screening all men, healthcare providers evaluate whether someone is at higher or lower risk for developing clinically significant prostate cancer and then counsel them accordingly. Next slide. So all of this was actually said before, but again, in assessing the risk factors, some of the main things that we look at: age, risk increases with age, family history of prostate cancer, which my group member already mentioned, ethnicity. For example, men of African ancestry may have a higher risk. Genetic mutations such as the BRCA and BRCA2 gene, personal medical history, and life expectancy. So what are some of the potential benefits of screening and some of the potential harms of screening? So some of the potential benefits: earlier detection of aggressive cancer, reduced risk of advanced disease. However, some of the harms: false positives, which we will talk about later, anxiety. Obviously, you're telling this person this, they are going to have anxiety, unnecessary biopsies, overdiagnosis of slow-growing cancers, and overtreatment causing urinary, bowel, or sexual side effects. So after our risk-based counseling approach, we also have the teach-back method. So what is the teach-back method? It is a communication technique used in healthcare to confirm that a patient understands important medical information. So instead of simply asking, "Do you understand?" the healthcare provider asks the patient to explain the information back in their own words. So the goal is to assess how well the information was explained, not to test the patient. So the key features of a teach-back method: you use plain non-medical language, encourage patient participation, identify misunderstandings immediately, improve health literacy and adherence, and it supports shared decision-making, which was talked about before. So some of the benefits of the teach-back method: research shows it can improve patient understanding, reduce medication errors, increase adherence to treatment plans, improve chronic disease management, and reduce hospital readmissions. So an example now of a teach-back method: a doctor may ask, to make sure I explained everything clearly, can you tell me the possible benefits and risks of prostate cancer screening? So you see, it's a little more detailed. It asks specifically, risk and benefits to see what the patient actually understands after you would have spoken to them. So let's talk a little bit about false positives and overdiagnosis now. So in prostate cancer screening, particularly with the PSA, two important potential harms are false positives and overdiagnosis. So a false positive occurs when the screening test suggests prostate cancer may be present, but the person does not actually have cancer. And overdiagnosis means detecting a prostate cancer that would have never caused symptoms, illness, or death during the patient's lifetime. So let's talk a little bit about both. So with false positives, how can it happen? You can get false positives with benign prostatatic hyperplasia, prostatitis, urinary tract infections, recent ejaculations, aging, recent prostate manipulation. So some of the consequences of a false positive, again, anxiety and emotional distress to our patient. Now you would have to repeat your PSA testing to ensure this is actually accurate. Unnecessary prostate biopsies can occur, and the biopsies themselves may cause bleeding, pain, infection, and urinary complications. So, overdiagnosis, why does it matter? So, screening for prostate cancer may identify small indolent cancers that may never progress, may never spread, may never affect quality or length of life. And some of the consequences of overdiagnosis, again, we have surgery, unnecessary radiation or hormonal therapy. And these treatments in itself can cause significant side effects as well, such as erectile dysfunction, urinary incontinence, and bowel dysfunction. So the key difference for us to remember with false positives and overdiagnosis: with false positive, the test suggests cancer, but no cancer is present. Overdiagnosis, cancer is present, but it would never have caused any harm. So, men's outreach. In Trinidad and Tobago, we have this initiative called It's All About Him, which is a health initiative for men. And these are some of the flyers that are actually displayed on websites and on social media. And I just put these two to let you all know that the screening that happens for men, they make it very opening to the entire population. So it's not only in your health facilities, because not everyone likes to visit a health center. Some people get anxiety and all these things. They also have it in other locations like, look, the Long Circular Mall, Trinity Mall, South Park. So they are going to meet you where you are so that you have a level of comfort when you go into your screening. Next slide. So the Ministry of Health, in collaboration with the regional health authorities, have embarked on days of planned prostate screening for men. And the aim of this activity is to increase educational awareness about prostate cancer and to encourage positive action in men towards their health. And the theme for this initiative, as already mentioned, it's all about HIM. And the HIM stands for a health initiative for men. Next slide. So these were some of the programs that Trinidad and Tobago did. There was actually one recently, a stress awareness fun day and health fair, which was on the 25th of April, 2026. But the Men's Health and Wellness Day really started in August of 2024, when they were offered by the Ministry of Youth Development and National Service for men aged 45 and above. That's when they really started to take the initiative more seriously to aim for early diagnosis and treatment for prostate cancer. And then they continued in November with a Men's Health and Wellness Day. This was at the Belmont Community Center. And now we have a men's clinic, which is a monthly clinic providing a comprehensive package of health services, including general medical assessments, prostate health, STI screening, and psychosocial support. So it's not only about prostate cancer screening, it's about everything that would affect a man. So obviously, when you and your patient come up with a decision of whether we are going to go ahead with our screening or not, you have to remember that documentation is very important, right? So documentation quality is something that we definitely have to speak about. So what to assess when you're looking at documentation quality? You have to create a checklist based on required elements. So ensure that you have the patient's age, risk factors such as family history, ethnicity, what symptoms the patient is currently having, discussion of benefits and harm, properly documented. If they had a PSA done, make sure that the result is recorded. Shared that decision making was make sure that you note that this was a shared decision making between you and the patient, and ensure that your date and signature is present and a follow-up plan documented. So how can we measure documentation quality to ensure that it's properly done? You can do chart reviews, medical record audits, and you can use standardized scoring tools or checklists. Next slide. So informed consent. Informed consent is very important when the patient says, yes, we are going ahead. I want to have this screening done. So what to assess when you are having an informed consent? Check whether the documentation shows explanation of procedure and or test, the benefits discussed again, risks discussed again, alternatives discussed. You'll see how important this is. Opportunities for questions and the patient's agreement or consent documented. Methods of doing this, you can have review consent forms, patient interviews or surveys, direct observation, and again, your electronic medical record audits. Next slide. So follow-up. I think in the healthcare system, this is very, very important. And I think sometimes it really gets lost because the volume of patients, and sometimes even now, remember, we have a lot of doctors who are cycling. We are not in one place for long, documentation, all these things. And it's hard to keep track of patients. And what to assess when you're doing a follow-up is to ensure that the repeat PSA, if needed, is completed. The urology referral, if a patient needs referral, is attended. If a biopsy is completed, if it was indicated, and if the results were communicated to the patient. I've had a lot of patients where I work, they would come in and say, I did the test 4 months ago. Every time I come, no one can find the result, or no one told me, or they don't understand. And, you know, a lot of things get lost in the system. So we have to ensure as healthcare providers that we really follow up these patients, especially the high-risk patients who need to have further treatment, especially if they have a high risk of having prostate cancer. And of course, if their follow-up appointment is attended. So how can we ensure that follow-up is completed? We can look at clinic appointment logs. We can look at referral tracking systems. Again, your electronic medical review, record review, and patient follow-up calls. Next slide. So in summary, bringing all this together, the Caribbean has among the highest prostate cancer incidence and mortality rates worldwide. Afro-Caribbean men at a higher genetic risk for aggressive prostate cancer. Screening is often opportunistic and influenced by healthcare access. And many regional experts recommend earlier screening, 40 to 45 for high-risk men, risk-based counseling, and shared decision-making, which is very important. Improving education, access, and culturally sensitive care may reduce prostate cancer deaths in the region. And the key message to take home, early detection combined with informed, individualized counseling is essential to improving prostate cancer outcomes in the Caribbean. And these are our references. Thank you very much.
Thank you for a comprehensive presentation. You mentioned visual aids, and I think that's important. What sort of population you think would benefit from using visual aids?
Definitely the older population, especially if you look at it, the older population, men and women, they are not really into that technological, or even most people who come in the public healthcare sector, they are usually of the more lower socioeconomic background. So, these are people who, some of them, they would not have finished all levels of education. So I think visual aids help them to actually understand. So like showing them a diagram of the prostate, because some of them actually don't know where the prostate is, and letting them know that, okay, if you can see it, I think they are going to be better able to understand what you are actually explaining to them.
So the use of visual aids in shared decision making is very important. That's what you're saying.
Yes.
Yeah. So persons with a low health literacy will benefit from it.
Yes.
Yeah. Good. I was happy to hear about your absolute risk, and it's important that you bring that in as well, and how it is explained to the patient, how it is communicated to them. You mentioned the BRCA 1 and 2, and is that a risk factor for prostate cancer? And how does that work? How would you assess risk? Is it like if an aunt is BRCA positive, that means to say that the person is at risk? What's the relationship?
From what I was seeing, most of the things they said, you would then have to do genetic testing on the patient themselves if you believe that there's BRCA genes running in the family. It doesn't necessarily mean that they have the BRCA gene, and only if they have the BRCA gene, then they would be confer a higher risk for prostate cancer.
So that would be the son of a mother who has it, who had breast cancer.
Oh yeah, he will be considered to be at a higher risk.
So what if she had ovarian cancer? Is there a risk?
If she has the BRCA gene, yes.
And also in looking up, in terms of the two genes, they said that the BRCA2 actually carries a higher risk than the BRCA1. So definitely, even when testing, if it's definitely BRCA2, they would have a higher risk of developing prostate cancer.
So those are questions we don't really ask males, do we? We don't ask them if their mother had ovarian cancer or breast cancer.
No, we don't normally do that.
No. What about diet and the risk of prostate cancer?
The only thing I saw was the increased risk with polyunsaturated fats. I didn't really see anything else in terms of diet.
And what about vitamin D and prostate cancer? Did you see anything with that?
I don't recall seeing anything particular with vitamin D.
Okay.
I think from what I remember, I think it's zinc and vitamin D supposed to increase your prostate health, but I'm not sure if it really had anything to do with cancer directly.
Okay. And if the BRCA1 or 2 gene is, how would you know when to do testing? how would you suspect when to do testing? Would you test that patient for prostate? If a patient comes in with an enlarged prostate or an elevated PSA, where does the BRCA 1 and 2 fit in?
I think that may you may want to consider that if you have a typically a young patient, if the patient does have a family history of breast or ovarian cancer, then you may want to consider it at that point.
To do genetic testing?
In that case, yeah.
Okay, right. How would you manage a patient whose anxiety is causing them to request for PET testing? Their
Well,
health anxiety is driving them to request testing.
So definitely, this is where we as the healthcare professionals, we have to really counsel our patients. And it's not just about just testing, it's a holistic approach you would take with your patients. So they definitely, if they need support outside, because sometimes, they are coming in the healthcare setting, so we would do the necessary referrals. So if you know that this patient is having a lot of anxiety, of course, you counsel them, you educate them, you try to understand their concerns so that you can help them to be less stressed, because if they do have a positive test and they have to go on to further treatment options or management, obviously when they leave us, we can't just leave them there, because they're going to go home and they're going to be thinking about it. So if proper referral channels, if they need to speak to a counselor, even medical social worker outside of our expertise, that would definitely help that patient as well.
Okay. And so if a patient comes in and asks for prostate examination,
The DRE?
The DRE, yeah.
That's very funny, because most men detest that. But if they actually, especially for Caribbean men, that is what I think deters them the most from PSA testing. Like they always say, oh, I don't want nobody, doing this test on me. So if a patient actually wants that, I would smile and I would actually talk to them and let them know that, okay, because I know some patients may come in and think that because they so want the test and they think that's the only option, they would do it even though they don't want it. So again, I would educate my patients and say, it's actually, it's not a first line. We can do the blood first, right? And once the PSA, based on the PSA result, then we can move on to see if you actually need that rectal examination or not. But I would let them know, it's not something that now the guidelines have changed. That's not a mandatory part of PSA screening.
Right. So would you follow up? Would you do a physical examination and then ask for PSA? What time frame you would look at and why? If you did physical examination.
If I did physical examination on the patient and he said, when would I do a PSA?
Yes.
Okay, so for me, it will definitely be looking at, of course, risk factors, age. So if a 35-year-old comes, they have no risk factors, and they're saying, well, I want to do prostate because I'm seeing a lot of men getting prostate cancer. I would tell him, based on your risk factors, your age, your family history, it's not indicated at this point in time. However, if another person comes, and again, that's why history is so important as part of examination, you're tying everything together to see if this patient actually needs to have a PSA done.
Right. So it is someone, there's a 58, 68 year old. And he is insistent, so you do the DRE. But of course, you have to follow up with a PSA. When would you tell him to do the PSA? Would you say to him that he has to do it tomorrow or the day after?
Well, in our setting, if it can, yes, I would tell him, because of his age, especially if he did not have a PSA done before, I would recommend that he does it. So I would do the PSA for him.
When? When is the ideal time?
Well, I would do it as soon as possible. So if in a setting where you can pull the blood on your own and it gets to go down the same day, I would do it. If he has to make an appointment, I would write the blood investigation form for him and let it be done as soon as possible based on the lab requirements.
So a
So
DRE,
just to add to that, I think when you do the DRE, you have the chance of elevating the PSA. It may be a minimal increase, and I think some guidelines say you should wait at least 24 hours before proceeding to do the PSA if you did the DRE.
yeah. I think you have to wait 2 weeks actually.
Oh, okay.
Yep, 2
Okay.
weeks.
That's good to know.
Yeah. And the other thing is that persons who are on Duodata or Avodata, that gives you a false PSA reading as well. The readings become, I think it's less than what it actually is. Or yes, it's less than or either more than, but it gives you a false reading, a false estimate. Good. So thank you very much for that presentation. Very, very informative. And the principles of shared decision making not only apply to prostate screening, but to other screening as well, other areas of screening, and in medicine generally. So thank you very much for sharing that with us. And we have one more presentation.
Yes, you do.
Yeah, so let's take a 5-minute break.
Okay.
Okay, are we ready?
Hi, yeah, may you hear me?
Yep.
Oh, sorry. Okay, so good evening, everyone. Our discussion today will be on cervical cancer prevention from screening recommendation to implementation. It will be presented by Dr. Chanel Mangal and myself, Dr. Mitra Mewala. So, so this is the layout of our presentation, and it includes introduction, prevention of cervical cancer, global initiatives, a case, some barriers with respect to cervical cancer screening, the guidelines associated with screening, Caribbean realities and adaptation, the practical strategies, evaluation plan, and conclusion. So cervical cancer remains one of the most preventable cancers affecting women globally. Usually, it is the most preventable cancer. It is currently the 8th most common cancer worldwide and the 4th most common cancer among females around the world. So persistent infection with high-risk strains of the human papillomavirus, or the HPV virus, is the primary cause for developing cervical cancer. So effective prevention includes HPV vaccination, cervical screening, and early and timely treatment of abnormal lesions. But due to burdens of low and middle income countries, this includes the Caribbean and our country, women continue to experience high morbidity and mortality from cervical cancer. So this is just an infographic highlighting from the Global Cancer Observatory, which is part of the WHO, the rank at which the incidence is number 8 and the mortality rank number 9 cancer in the world. So this data from the HPV Information Center shows and highlights Trinidad and Tobago human papillomavirus and related cancer fact sheet in 2023. It showed that Trinidad and Tobago back then had a population of 630,000 women ages 15 years and older at risk of developing cervical cancer. Estimates show that every year, approximately 202 women are diagnosed with cervical cancer and 127 die from the disease. So cervical cancer ranks as the 3rd most frequent cancer among women in Trinidad and Tobago. It is the 2nd most frequent cancer among women between ages 15 to 44 years of age. So some of the risk factors include persistent high-risk HPV infection, and these include type 16 and 18, early sexual activity, multiple sexual partners, smoking, immunosuppression, long-term oral contraceptive use, and high parity. So moving on to prevention of cervical cancer, it can be classified into 3 categories. So primary, secondary, and tertiary, right? So with this picture, it shows you have to have a strong base, and that involves primary prevention, and this includes education on cervical cancer to the population, education on safe sexual practices, appropriate adolescent sexual health education, HPV vaccination, and health information and warnings on tobacco use. So moving up, the secondary prevention, that would include screening and treatment of precancerous lesions before progression to cancer. And the tertiary prevention, this would include treatment of invasive cancer, which involves a multidisciplinary approach prior to treatment decisions. So this would also include procedures such as cryotherapy, surgery, radiotherapy, and even palliation. So there was a global initiative by the World Health Organization, and it was called Cervical Cancer Elimination Initiative. It was the World Health Assembly convened in August 2020, and they formulated 3 pillars, and it greatly resembled the 3 pillars, the primary, secondary, and tertiary prevention. So with this, the vaccination was the first pillar, where it suggested that 90% of girls fully vaccinated with HPV vaccine by age 15. So all countries had to agree to reach that in order to accomplish the first pillar. The second pillar, 70% of women screened using high performance tests by age of 35, and then again they would be screened again by the age of 45 years. So screening was the second pillar, and that's a percentage of 70%. Treatment, it includes 90% of women with pre-cancer being treated and 90% of women with invasive cancer being managed. This kind of encompasses both a bit from the secondary and tertiary prevention. So each country should meet this 90, 70, 90 target by 2030, and this will help in the elimination of cervical cancer within the next century. So our case involves a 42-year-old female who was seen in the health center, and from her note, she was found to not have a cervical screening in 10 years. She gave reports of embarrassment, fear of results, difficulty getting time off work, and misinformation from social media. She said she would rather not know if something is wrong. So going forward, cervical cancer screening, it entails testing adult females for precancerous cervical cell change. So when treated, it prevents cervical cancer from developing. And then sometimes cancer can be actually found during cervical screening. Cervical cancer found at an earlier stage is easier to treat. So some of the screening tools includes the cytology or the pap smear, HPV DNA testing, the HPV and pap smear, so that is done together, and also the visual inspection with acetic acid. So the visual inspection with acetic acid is a simple, widely feasible and affordable screening tool. It requires minimal infrastructure needs and can be provided and used by a wide range of professionals. Results are usually immediate and patients can be treated. So with the pap smear, these are the tools that we use, which is the speculum, the wooden spatula, the brush, and the glass applicator. So basically, the sample are collected, and with a spray fixative, it is used to test cells of precancer, to test for precancerous cells in the cervix. And if but with this test and the results take a bit longer to come back. So usually 1 to 3 weeks, ideally. But in our population of Trinidad, our setting, it takes, well, we tell patients in the health center 6 to 8 weeks, right? So disadvantages is long waiting time. With the HPV DNA testing, usually a sample of cells is collected from the cervix or the vagina using a small brush or swab and sent to the lab for processing. So it detects the DNA from the high-risk types, which is the 16 and the 18 type of human papilloma virus. So with the advantages of HPV DNA testing, the samples can be collected by a trained professional in some cases, or it can be collected by the patient themselves. But the trained professional swab usually the cervix, and the patient usually swab the vagina vault. So it is higher in sensitivity compared to the pap smear and is more effective in women 30 years or older. Usually this will require follow-up visit if done at home or even by the medical professional, because it takes 6 to 8 hours for results to come back. So ideally, you would have to come back to review the results. So usually, a pack usually comes with the instructions and it involves it gives instructions to the patient to how to perform the test. So with barriers to cervical cancer screening, the clinical and behavioral factors linking back to the case, the patient had fear of the results and embarrassment. So basically, when women delay with cervical screening, cervical cancer, they usually, when women may delay screening because of cervical cancer, it may be asymptomatic early on, so the absence of symptoms is wrongly interpreted as the absence of risk. So they may also have the fear of pain, fear of results, and the avoidance of bad news. So in this case, with our patient, communication is important. Poor counseling can lead an increase in fear in the patient. And if the patient does not understand about the disease, the human papillomavirus, the precancerous cells, the abnormal results, they may avoid the test entirely. So counseling is very important. and WHO and PAHO both emphasize education and informed participation as core parts of prevention. With misinformation on social media, this can deter women from believing the screening is unnecessary, it is dangerous, sexually stigmatizing, and only needed when symptoms appear. With respect to social and cultural factors, the patient's embarrassment, is a major issue, and it must be addressed. In the clinical setting, pelvic exams can be experienced as exposing, sometimes shameful, and socially uncomfortable, especially when there is a stigma around sexuality, reproductive organs, or cancer itself. Women may also fear judgment, loss of privacy, and even rumors in close-knit communities where they live. So the same study, there was a study done back in June 2025 by Professor Maraj and Dr. Khan, and it highlighted, it found that embarrassment by the physician and beliefs that pap smear testing interferes with sexual function, both were significantly associated with non-screening. The economic and access factors, difficulty getting time off from work is highly relevant in our case, right? So even if screening is free in the public setting, women still have to face indirect costs such as transportation, loss of wages, long waiting time, repeated visits because of the length of time the results take to come back, right? Sometimes common interventions to improve access include out-of-hours screening, alternative screening centers, mobile services, so going to the patients in the rural communities, and patient navigation. For the health system factors, usually, again, poor follow-up of screened patients. So basically, because of the frequent visits, they are lost to follow-up, and delay in results after this, right? So there's a low uptake. Low uptake is also a systems problem. So major barriers would include population registered, weak invitation system, insufficient monitoring or participation, poor follow-up of screen positive patients, and delays in treatment. So the screening recommendation, we just highlighted one from the National Cancer Institute in conjunction with the American Cancer Society. It highlights that it was recommended that before age 21, no pap test is recommended. It starts at 21 to 29 years. The first pap test or the pap smear is done at 21, and then 3 years, every 3 years after. 30 to 65 years, recommended to have either HPV test done every 5 years, but the recommended one is HPV pap co-test done every 5 years, once negative, right? And the pap test can be done every 3 years. So older than 65 years, patients are recommended to speak with a healthcare provider. So if screening was done regularly and all the screening was normal, then screening is no longer needed. But if patient was not screened regularly and there was abnormal results, then screening actually continues beyond 65 years. And there are more frequent screening if the patient has HIV positive results, if they are immunocompromised, if they ever had a positive biopsy done, they would need more frequent screening. So in our Caribbean neighbor in Jamaica, the government actually subsidized cervical screening tools for women ages 21 years and up. And this included the HPV DNA testing, just to reach out to the community to encourage patients to be tested more. Right? In Trinidad and Tobago, it almost resembles, it is similar to most international bodies. Again, screening begins at age 21. 21 to 29 years, pap smears are done every 3 years. 30 years to 65, we do have the pap smear in local health center, but not the HPV DNA test. So unless available, it is recommended every 5 years. And basically, it closely resembles the previous recommendation as before. So with respect to the human papilloma vaccine, the HPV vaccine, vaccines are available in the local health center. It is the Gardasil, that is the name of it, is a quadrivalent vaccine covering for 4 types, the type 6, 11, 16, and 18, and currently is a 2-dose vaccine. Ministry of Health, they has a school-based outreach where they target the boys and girls from the transition from primary to secondary school, and with the parents' consent, they encourage vaccination. But currently, there's a low uptake in the vaccine, approximately 19% and 8% of HPV vaccine coverage for the first and second dose, respectively. And the barriers for this would include is mainly due to education and availability of the vaccine. So this was back in March 8th, 2023. That day was International Women's Day. The Ministry of Health had embarked on a major health and wellness promotion, a campaign to educate and provide screening services to reach out to the public for both cervical and breast cancer, right, in all regional health authorities. And that is in keeping, well, they try to do this to educate the population to increase the numbers, to get it up to the percentage of the 90, 70, 90, right? With this, it shows there are multiple stories out there where it covered in the newspaper showing how prevalent cervical cancer is in Trinidad and Tobago, even affecting both young and older age group. Most of these patients were actually asymptomatic, and this highlights the importance of screening in our population for early detection and treatment. So I'll hand over to Dr. Chanel to present.
Hi, good night. So ideally, a screening register system is an electronic database and population health management tool, which is designed to manage, monitor, and improve participation in cancer screening programs. And this would be found, of course, in our first world countries like the US, Canada, Australia. And unfortunately, Trinidad and Tobago has no formal screening registry systems. Data is usually collected manually from our cytology lab logbooks, and screening would be done largely independently by the different RHAs. So Trinidad and Tobago relies largely on opportunistic cervical screening rather than centralized screening registers. And the contributing factors for this is that we do have a very fragmented healthcare system, limited digital infrastructure, funding and staffing constraints, as well as the historical absence of organized population-based screening programs. Now, we do have a cancer registry called the Dr. Elizabeth Kwamina Cancer Registry, which just records cancer cases. Next slide. So we also have the Trinidad and Tobago Cancer Society, which is a non-profitable organization focused on cancer prevention, awareness, screening, and advocacy and patient support. Their initiatives would be screening programs, providing public education awareness, cervical cancer awareness campaigns, patient and family support, advocacy and public health collaborations, as well as community outreach initiatives. Next slide. So the reminder and recall system is important for us to look at it in a flow in this way, where we consider screening, where we have our pap smears done, we follow up with the results, and we have a recall system where the appropriate referrals and follow-ups are done. So we could do this via our SMS reminders, our phone calls, WhatsApps, appointment cards, district health worker follow-ups, contacting missed patients, fast-tracking abnormal results, and flagging high-risk patients. Now, as we've mentioned multiple times before, yes, we do provide the screening, but we have patients that we tell you're coming back in 6 to 8 weeks, and months sometimes go by and patients don't get results. So the time it takes for the samples to go to the labs and then come back to the clerks and going back into the patient's file, there's loss sometimes, a lot of times, and of course, this is detrimental to our patients. Next slide. So, of course, women will prefer a female-friendly clinic service. So women would prefer female providers. You must provide an environment that is private and respectful. As reference into our case, providing an evening and weekend clinic for the working woman, having dedicated women's health sessions, and we must try to avoid trauma by explaining procedures, obtaining consent, and respecting patients' dignity. Next slide. Um, so addressing fear, shame, stigma, and embarrassment, again, tying up with our case, the most common fears would be fear of cancer diagnosis, embarrassment, and fear of pain. So here's where we take our time to educate patients, letting them know that HPV is common, and screening most times would find pre-cancer before it develops into cancer, and abnormal does not always mean cancer. Screening is more of a preventative approach rather than a punishment, and follow-up saves lives. So how we go about doing this is, of course, taking a non-judgmental approach, avoiding medical jargon. So I actually had a patient recently in emergency who was told that they have bacterial vaginosis from their pap smear, and they were terrified. And of course, to us, we might not be, but to a common man, it may be terrifying news. And this is why it's important for us to take our times and counsel patients, especially those of the low IQ, for myth busting education. So some common myths people have would be only promiscuous women can get cervical cancer. And this is actually very untrue, as exposure to just one partner puts you at risk. They're either too young or too old for a pap smear. Pap smears are not needed if they are asymptomatic, as we saw in the articles provided. A lot of these patients are asymptomatic. And the HPV vaccine is dangerous and it causes infertility. And I think this is a common issue in our schools that parents have, that if we give their kids the HPV vaccine, we will affect their fertility. So it's important, again, for us to educate our patients. Next slide. So I actually found these pamphlets and posters from the Trinidad and Tobago Cancer Society. These were posted on Facebook in January, actually January 2026, as this was our Cervical Awareness Month, and they were very patient friendly, and it explained it very nicely for patients. So it's something patients could have a look at. Next slide. Right. So besides the pamphlets, posters, when patients go into the public health, the GP offices, and so you could have the waiting rooms, you could have the videos being played, lectures being played, having community talks, and social media outreach. Next slide. So when we think about community outreach strategies, we want to focus on places like workplaces, churches, community centers, health fairs, where we have partnership with the NGOs, faith leaders, women's groups, and our community health workers. The goal now is to normalize screening and reduce stigma. So when you're shy, person from church sees their peers going to have the testing done and they come back and say, well, it wasn't that bad. They may be encouraged to have it done as well, and this goes a long way. Next slide. So patient navigation for abnormal results. So the role of the navigator is scheduling, follow-up, and coordination. How do we go about navigating for abnormal results? You must have timely follow-up where you're expediting diagnostic resolution for abnormal screening, addressing logistical, emotional, and psychosocial barriers, providing support and education. So of course, we take our time to explain medical jargon. This is an important one to explaining the next steps. So you can't just tell a patient, well, your results abnormal, bye, providing emotional support, having improved adherence. So once we have the structured navigation in place, it reduces your loss to follow-up and the role of continuum of care. So you're connecting the patients from abnormal screening to diagnostic resolution to treatment, thereby improving your survival rates. Next slide. So these are some initiatives our ministry would have taken. This is the Cancer Center of Trinidad and Tobago, previously known as Augustus Long. It was officially commissioned in December 2024, and it was established to replace the overcrowded oncology unit at San Fernando General. And there's also the Colposcopy Center at Mount Hope Women's Hospital, which is very accessible. Next slide. So again, this is a bit repetitive, but referral pathways and tracking systems are important to prevent delayed cancer diagnosis. So it starts at the primary care level. We have your abnormal results. You would tell the patients who need to have colposcopy and then follow up with their treatment and follow up as necessary. And these tracking systems would be things like your referral logs, missed appointment alerts, and follow-up calls. Next slide. So the evaluation plan, so the key indicators would be things like your screening coverage rate, as Mitra would have mentioned, ideally coverage should be greater than 70% of your target population. Results notification, monitoring the time between abnormal results and colposcopy, completion of recommended treatment, patient overall satisfaction score, community outreach, the no-show rate for screening appointments, as well as the monitoring the reduction in advanced cervical cancer over time. Next slide. So in conclusion, cervical cancer is quite preventable. The barriers could be personal, cultural, and systemic, which we discussed. Patient-centered approach improves the uptake, tracking and navigation reduces follow-up, and Trinidad and Tobago is moving toward incorporating updated international recommendations, which is the HPV DNA testing into the public sector. I think it's just a matter of funding right now, as well as improving the triage pathways and structured follow-up systems. Yes, I think that's the end of it there. And we have our references.
Oh, sorry. I was muted all the time. Can you tell me when the vaccination program was started in Trinidad? Hello? Hello?
Right.
Yeah.
Right. So it's not sure, to be honest.
Hey, Doc, sorry you were breaking up a little. Could you repeat the question?
When did the vaccination program start in Trinidad?
In the Ministry of Health, that would have been around 2013, 2015, around there.
Okay. And have we been able to record a decrease in the incidence of cervical cancer? Oh, not sure.
The prevalence is 60%. That's with screening, but I don't think so. Because the rate at which cervical cancer is occurring is still high.
So are you saying that the primary prevention vaccination has not had an impact?
Yeah, because the rate at which it the 16% and 8% respectively for the first and second doses. So it is pretty low as compared to other countries where Australia actually have like a 81% and a 78% with the first and second. But that was recently, and they dropped from a higher number. So it's pretty low compared to other well-developed countries. So I guess we have to do more work with respect to reaching out to the communities and educating the population But
Definitely.
the nurses are doing the outreaches in the primary schools. So that's one way, and well, with the continuous visits to the health center, hopefully with the video loops and the lectures, we get the message across.
Yeah. How would you measure whether your intervention reduced inequity, not just increased total screening numbers, but how it reduced inequity? How would you measure that?
Maybe you could do like a patient satisfaction questionnaire for everyone, just to see. And from the biodata, you will know their socioeconomic status to know, okay, who was treated differently. I mean, that's probably one way to assess.
You'll be able to find out, to investigate where they are from, what sort of from their demographic information.
From the history, and yeah, you can find out, yeah.
And what sort of changes you think in order to decrease that inequality or inequity? What changes you think would you make at a clinic level to improve cervical screening uptake in working women? How can we improve there?
Well, as we mentioned before, you can reach out, well, have your outreaches, so you could go into workplaces and this, of course, as I said before, with these women seeing their peers having the test done, they may be encouraged to do it themselves. So having these outreaches would be important.
And another problem that we face in our clinics would be being able to deliver the results on time or deliver the results altogether, because some results get lost. How can we address that?
Well, definitely, if we could have these results electronically updated rather than being printed on a paper, which is what we do, and then stuck in a file, that may eliminate that loss of results.
I mean, you see it right now in the health center. Before, this is an example, we had with respect to urine MCS, it was paper-based before, and it was to take 2 weeks to reach the health center, but now is via database and is linked to the SWRHA database as well. So your computer in the health center actually could pull up the results 2 to 3 days after. So you could liaise with your patient to come in at an earlier time than 2 weeks, or that it was before. So definitely having and they get results quicker. So definitely having the electronic database where you could actually do it yourself and have your logs with your patients that they did the pap smears, and you could you could actually liaise better with them. In that way we could see like a change.
Yes. And where can one get the HPV test done?
Usually, well, it's done privately. I think up north side is, I think, St. Augustine Medical. I saw as one place, usually they have it there. So
it's not yet available at the hospital labs.
No, in health centers, no, not as yet. It's just the pap smear testing.
Okay, all right. Okay, so thank you very much for a very informative and well-designed presentation. I'll open the floor if there are any questions from the group.
Hi, sorry, I just have one question with respect to the screening pap smears, right? You're saying it's every 3 years, and if it's negative with HPV, it's every 5 years.
5 years.
I'm 65 years old. What is the reason? So I know we don't have the HPV, in healthcare setting in terms of health centers. So what is the reason for the above 65 not doing the pap smear? And because why is stopping at 65? And in this case, seeing that we don't have it, we're still supposed to routinely do it every 3 years then. So why do we stop at 65?
Yes.
Does that have to do with wait, I'm not supposed to answer, sorry.
No. I guess it's for anybody who knows because I really wasn't too sure.
I assumed it was the prevalence of or the incidence rather is the correct word of new cases after that age. Probably the incidence of cases isn't high enough to justify screening after that age group. Maybe the screening causes more anxiety than it does actually prevent worsening of cases or picking up on anything. But I don't actually have a sure answer.
But didn't the guideline or one piece of the slide said that the criteria is they had to have a history of negative pap smears before and
Yeah.
then cut off at 65?
Right. But so that's my question about that. Is that okay? Why the negative pap smears that causing it to cut off at 65, right? And also in our setting, we do have the HPV, so that means we still have to continue routinely doing, because I actually seen the health centers, nurses tell the patients they don't require a pap smear after 65. And I know we don't have the HPV, so I don't know how we screen that. So is it that the elderly group can still get cervical cancer, and I've seen it happen, and it's missed because we don't screen. So I was just in screening this case. So I was wondering why I wasn't too sure. So I was just asking. I don't know if that could help us out with this one.
Sure. I was giving the presenters a chance to answer. And first of all, as was said, if you've had negative ones, if you've had 3 consecutive negative ones, negative pap smears or 2 negative pap HPV, then that's okay. But the human papilloma virus takes a very long time to become cancer. So just as in prostate cancer, they think that, okay, so even if you do have it, it means to say that it will take 10 to 20 years where it is that it could present as cervical cancer. That's one thing. The other thing I think is that if a person at that age has new partners, I think it's important that they get tested as well. Because remember, HPV, it's not only male, it's not only female, it's males, right? So I think I would do that for my patients if they have new partners to test them. And likewise, if they had 3 consecutive tests, negative tests, then it should be they would be okay. So it really has to do with the length of time the HPV takes to make those cells cancerous.
So right, I thought about that as well, but persons are living till 80 something years old. So some persons might be infected in their 30s and get it at 50. So with that same reason, because that's why I was like, I don't understand why they did not screening for the patient. So that's why I was like, if you stop at 65, patient is 75, some people reach 80. Is it that because they're in an older age of life and may not survive, or because they're coming on to the end of stage of life, we don't screen for it? Because it's the same thing in terms of it could take 10 years, it could take 20 years. So I kind of just confused about that, to be honest, because I just want to do it still regardless, but I just wanted to understand why we stop. And if there's like maybe a study or something saying that, okay, over 65 with 3 negatives, like, and I just was wondering. So I may be asking a difficult question. My apologies to the group. I apologize.
No, it's a very relevant one because we do have a population that's living longer. But even if you've had that, if you're infected with HPV at the age of 50, you will pick it up. You will pick up changes before 65.
Okay. Thank you.
You're welcome. I hope that clears up something. Any further questions? Okay, so
I
thank
have
you
a
very
quick
much.
question if it's okay.
Sure.
Well, seeing the
Well, all the presentations I found were very informative, but the prostate cancer and the cervical cancer one, in terms of following up on the results, especially for pap smears, I was just wondering if anybody had any ideas on how we could improve that system, because even where I am in QPCCNC, which is supposedly supposed to be getting it back even faster, I think, because we would be screening symptomatic people sometimes. It's an issue, the length of time. So is it that maybe our lab is overwhelmed? Is it an issue with the courier? Is it an issue with dispatching, typing and dispatching? Like, if anybody has any ideas or any insight into it, because it's important.
Yeah. Anybody?
Because I actually don't.
All I
I
can
don't.
say is that, like at the health centers that I am at, the nurses are the ones who kind of follow up on it. So they might have a book with the pap smears and how much listens to the pap smears and the names. So they follow up with it for the lab. So they continuously chase the results for those patients. So that's one end. But if it's lost or misplaced, I guess in the doctors in that thing, if it doesn't come back in a particular duration of time, then recommended is to repeat it. I know it might be traumatizing for the patient, but if we don't have any direct information, then that's the best next thing, because we wouldn't really have direct information from the labs, because sometimes it outsourced to different labs within maybe a region.
So I figure there could be multiple reasons why in different systems, because it does go to different labs, right? Like Southwest will have a different lab, or North Central will have a different lab. And I think it has to do with the pathology. So I think what we can do, or what you can do, is to follow the workflow of the and see where is that bottleneck. What really, where is it? Is it at the level of the pathologist? Is
Right.
it difficult to say? You have to really follow it and find out.
Okay.
So that's for you to investigate, and then you
I
can
will.
implement something. Yeah.
Yeah. Thank
And
you.
sometimes it's simple measures could improve, could make things improve so
Yeah,
much
like
more.
just to delegate somebody or something.
Yeah, yeah,
Okay, thanks.
yeah. And sometimes even those persons who have to collect the results, sometimes they don't understand the bigger picture then as to why it is so important. I found that when people don't see the big picture, when they don't understand the ripple effect of what their actions are, the inefficiencies could take place. So sometimes education would help.
Okay.
Yes, so thank you very much for a wonderful presentations. And we will see one another next week, Tuesday.
Thank you.
Yes.
Okay, good night.
Good night, everyone.
Good night.